You got 3 sessions to explain that. And you got 3 sessions to ask those questions. Now I'm going to introduce Dr. Andrew Theory.
No, it's fine.
who's very patiently sitting over here.
Fascinating conversation.
It is a fascinating conversation. I can tell you this conversation we can have for a really, really long time. But the only thing I want you to know is that I put this whole thing together, this talk, which I am sharing with Dr. Theory, took me probably, I don't know, 30 hours to put together, right? So we're going to have a really interesting conversation about false negative MRIs.
Yeah.
Is that what you're going to do?
Yeah.
All right, so Dr. Theory is a radiologist, world-renowned, most amazing doctor ever, one of the most amazing doctors I've ever worked with. I'm trying to look for who else there. So he's going to talk about probably one of my most favorite topics in medicine, which is false negative MRIs, meaning that an MRI was done, but the findings were either minimal or not at all, and yet there's actually an injury to the patient. And yet we end up making our decisions based on the imaging, not on the clinical. That's a problem that we're facing in our industry. People are leaving their clinical judgments and relying more and more on the imaging findings. And I actually, against my own industry, do not believe that. Because you get a picture in time, photo in time, trust your judgment. That's what I say. So, Dr. Theory.
Thank you. Is this on? Yeah. So thank you. Yeah, this is put together by my mentor, Dr. Khan. So if anyone's familiar with expert MRI, it's actually a very unique approach that Dr. Khan has designed for imaging. The standard is pretty much you have a closed MRI or an open MRI, and the patients are supine, laying down, which is good for brain and some other joints, but for spine specifically, and I'll show you why this is the case, it can underestimate or really hide a lot of pathology if you're not doing different things based on the clinical presentation. And back pain is very common. Some people have back pain and then it goes away. Some people make it to imaging and there's findings. Some people there isn't. It's an underwhelming MRI, which leaves the clinician scratching their head on what to do next. And we deal a lot with surgeons, orthopedic surgeons, spine surgeons, as well as attorneys. So there's a lot, there's a lot of people that are really relying on what we're finding, or what we find. So this is just kind of elucidates the problem. A lot of individuals, in fact, a majority that have back pain have no demonstrable tissue pathology, which brings up cases of, is this patient making this up? Are they really hurt? That can put patients in a difficult position when their physician doesn't believe them. So there's different reasons why you may have what we call a false negative MRI or a quote unquote normal or underwhelming MRI in a patient that presents with clinical symptoms. The first one, radiologists, their levels of training are different. So some go to, some don't do a fellowship, some do fellowships in neurological imaging, so they're spending a whole year just looking at brain pathology. There's, in my case, I did orthopedic imaging, and there's other fields, pediatric, et cetera. So a lot of reports, if anyone's, I don't know if you can read that if it projects well, but a lot of reports just kind of describe, not much going on. You can see on this one in particular, I forget what it says exactly, but it's like, underwhelming, no specific, no significant disc protrusions. But you can actually see on the images, we like to describe all of these findings. It's actually very helpful for surgeons to know, that this is a normal disc, and these two discs here have desiccation or drying out. They're not healthy discs. And that's significant, especially in a patient that's had a traumatic, like a car accident or something, because you can have a systemic disease that results in degenerative disc disease, or you can have a post-traumatic. The post-traumatic kind or flavor, especially when you have a younger patient, you'll see a lot of normal discs, and then there's certain levels that are affected, whether it be from like a seatbelt injury or a whiplash injury. And this one also, underwhelming, kind of no real disc disease. And you go back and look at the images, there is disc desiccation at several levels. There's straightening of the lordosis. This is significant. A lot of patients have muscle spasm to stabilize the spine, and that can be very painful, and it can be it's a feedback loop that's very difficult to break and needs to be treated. But also, there's things like facet. These are the facet joints here posteriorly, resulting in significant central canal stenosis and neural foraminal narrowing that was not described on the report.
So what happens in today's world in radiology that is if I may?
Yeah, of course.
Is that we're reading images. This is okay. Yes. So what happens is we're actually reading images off computers, right? So have you ever scrolled through a Word document really fast? If you scroll through a Word document on your computer really fast, will you miss words? Right? If you go too fast, you'll miss words, right? So that's part of the issue we have in radiology. If the radiologists are too much of a rush and they're scrolling, because in the olden days, remember we used to have those films, and we'd put them up on the conveyors, and I know you don't even have any idea what we were talking about, but it used to be we used to put films up and then conveyor belts would go, and we had a chance to look at each image, image by image. In today's world, we're scrolling, and when you're in a rush, you scroll too fast, you might end up actually missing significant findings, and that's what happens a lot in today's world.
Yep.
I'm an MD, Harvard University, did my fellowship at Harvard. I'm a radiologist. I'm really good, okay? I'm really, really good. And because I'm so good, yeah, I'm really good, right? I'm an interventional radiologist, okay? And I looked at that image, and I believe, okay, that this person has degenerative changes or disc pathology at the L4, L5 level with potential disc bulging and herniation. This could be causing compression of the fecal sac, and depending on the clinical symptoms, might be responsible for nerve root compression and spinal stenosis. And I would treat it with conservative management, first-line treatment, with rest and activity modification, physical therapy, pain management, non-steroidal anti-inflammatory drugs, muscle relaxants, corticosteroid injections, and lifestyle changes. Beyond that, I would go to interventional pain management if the conservative measures failed, with an epidural steroid injections and nerve blocks, and with minimally invasive procedures with microdissectomy, percutaneous disc decompression. Furthermore, I go to surgical intervention if necessary with a dissectomy or lamictal spinal fusion in more severe cases. Alternative therapies, I would recommend chiropractic care and acupuncture massage therapy. And when to consider surgery, I would consider surgery if conservative treatments fail to improve symptoms after 6 to 12 weeks, if there are signs of significant neurological deficits such as muscle weakness, severe numbness, or loss of bowel bladder control. Cauda equina syndrome. This is a surgical emergency that requires immediate attention. Prognosis, many patients with disc herniations improve significantly with conservative care within 6 to 12 weeks. Anyway, I just took a picture of that. And that's the radiologist who just gave me that answer. Diagnosis and treatment plan. Well, what I recommended. Can you imagine if you had this in your hands, right? And you could just take a picture, right? And say, help me with understanding this. And you could zoom in on something and say, look at this closer. Now, this is just with a low-resolution picture I took of your slideshow. At a DICOM image level, what this thing could do to assist you in diagnosis is unbelievable.
Yeah. I mean, it's very general. That's like just kind of textbook. It's not really specific to the patient, and it sounds very expensive.
I don't know what questions.
It threw everything at it, which is very expensive. So payers are not going
I just don't know what questions
Cares
to
or
ask
not,
it
yeah.
yet. If I knew what
Yeah.
question, I guess
Yeah,
I
yeah.
would go deeper.
I mean, what we're always trying to do is drill down to like very, very specific. Like, there's some cases where I'll have a surgeon call, and they'll say they'll know exactly which distribution this patient's symptoms are, like a radiculopathy. So they'll be like, can you look at these images again? There's some I have clear pathology, or, clear clinical symptoms and the distribution of the right L4 nerve root. And I'll look back at the images, and where we usually look, there's nothing really going on. But then, looking at the whole patient, there might be something out in the abdomen that's, pushing on, which is actually darker on the images, because that's not part of the lumbar spine. So, but yeah, that's general. I mean, I would imagine it could get more specific as it's, if you're looking at a lot of MRIs and training it, but.
Just give me a diagnosis, and I said, how do you treat it? That's all I said. I didn't did that diagnosis.
But what the diagnosis on that is a degenerative facet cyst, which results in moderate to severe central canal stenosis and neurofemoral narrowing, and the treatment for that is to drain that cyst, or so so you can specify it. That was very general, but you'd want anti-inflammatories, and you'd want.
This discussion actually is, to be honest with you, it's actually not relevant to what we're trying to get to, because you're taking a photograph from a PowerPoint of really low resolution. You don't have digital information, so what it can do is way more than what we're going to be able to show right now, because then it's going to go into a lot of things that we as doctors are going to say, wait, no, this is going down the wrong path, because you just took a picture from a low resolution. Now there will be some pictures I can show you here that if you took a picture of it, you actually would get more specific answer. But that was a very complicated low resolution question. What this is going to show you is that where AI is not going to help you. Okay? Go to the next slide. Okay. Yeah, exactly. Well, no, go ahead. So let's go. Yeah, but watch this. You guys are going to get shocked about some of the stuff.
So we're we talked about the quality of the reporting, radiologist interpretation. Also, scanning in the wrong position is an issue. The dominant motion obviously is in the cervical and lumbar spine, flexion extension. Those discs are load bearing from the skull, and from in the lower back. This is just showing for those that aren't as familiar with MRI machines. This is the typical closed MRI unit. You have a donut that contains the magnet, and then you have a bed. So the patients lie down flat on their back, and then they're scanned. Whatever body part is that we're trying to look at will be imaged. And then this is kind of the traditional open MRI. You can see it's open on the sides here, and it's shaped differently. Lower field, usually the strength of the magnet isn't as high, so the quality of the images isn't as good, but a lot of patients can't tolerate, if you can imagine, a lot of patients can't tolerate this. And then there's front open MRI, which is what we have at Expert MRI. And with these machines, you can have patients sitting up, and I'll show you why this is important. You can have them in flexion, extension, neutral, sitting, different angles. And this is really useful, especially for spine imaging in patients where their symptoms vary based on position. A lot of times you have a patient that completely, when you're doing your history, I have, really bad pain when I'm bending over, or extending or laying down, etc. So you really want to elucidate how the symptoms change with position. These are just a bunch of articles talking about multi-position MRI and its usefulness in diagnosing a lot of this stuff. So keep in mind, at the beginning of the talk, I was saying almost all imaging is done supine. So this is different. This is additional capability that if you just go to any MRI center, overwhelming likelihood is that you will just have your imaging done supine. And the reason why this is important is there's been there are a lot of papers showing that findings that are missed on the supine study are accentuated or present on the multi-position, standing MRIs, weight bearing, et cetera. Supine is laying on your back, yeah. And they're not insignificant changes. So just a little bit of rudimentary. We already went through some of the anatomy on the first day, but vertebral body, intervertebral disc, vertebral body. So you have ligaments, they're stabilizing, just like any other joint, like the ankle, you have ligaments that hold the bones together, keep them from translating and rubbing off the cartilage. In this case, you have intervertebral discs, you have the longitudinal ligaments that stabilize the spine.
Yeah, both, yeah. So what's critical here is to understand that I'm sure you can tell. The picture on the left versus the picture on the right. Okay. What's the question? Well, let me finish. When you finish the slide, then we can ask the question.
So, as far as what things can be injured, things can be, cause pain. We heard a talk about intervertebral discs. There's facet joints back here. In the setting of trauma, you can have ligamentous injuries with instability. This is, intervertebral disc, and this is just kind of demonstrating, as you would imagine, the intervertebral discs are shock absorbers. They absorb weight. And when they're healthy, they perform very well. When they're not, it creates problems. And you can have pain generating from the disc, from the facets, from instability, et cetera. So this in the bottom left here, this is important, and this is showing, so this is a patient lying on their back. This is the relative pressure at I think it's the L3, L4, or L4, L5 level. So they're measuring the pressure inside of the intervertebral disc and how that changes based on the patient's position. So, and it's relative. So lying down on the back, the relative pressure, 25. When you have this person stand up, this is lying on their side, standing up, it's a 4-fold increase in pressure at that level. So as you can imagine, it's going to be squeezing that disc. If there's an annular tear in the periphery of the disc, you're going to accentuate that herniation. Or if the ligaments aren't healthy, it's going to accentuate instability. And this is just going through bending over or flexion with weights, et cetera. So you can see the position has a huge effect on the relative pressure at these intervertebral disc levels. So why is this important? This is a supine study, meaning the patient's lying on their back. This is done in extension, and it's showing, you can see, these are fairly normal, healthy discs. You can see these are abnormal. There's dark signal there. They don't have as much fluid, normal fluid. There's blood vessels it's live tissue, so there's blood vessels that feed, oxygen and nutrients to the intervertebral disc. If those little tiny vessels that perforate right here at the end plate are disrupted from shear forces or from things like cardiovascular disease, you're going to start to see them degrade. This is pretty significant degradation of the intervertebral disc here. But what's important between these two is you can see at this level, this is L3, L4, you have a significant anterolisthesis or instability. This is unstable by definition because it changes with position. You can also have fixed spondylolistheses, but this is even more of an issue because it's unstable. And you can see, if you're just getting this MRI, there's some disc pathology, there's some disc protrusions. Yeah, it's narrowing the central canal here, but it's not pushing on any nerves. When you get it, actually this is upright. You can see that it accentuates this anterolisthesis. There's compression of the cauda equina. In that AI answer where it was talking about bowel and bladder dysfunction, that's the result of the compression of the cauda equina. Cauda equina is the nerve roots as they, this is the basically the end of the thoracic cord, spinal cord, and then these are the nerve roots that then exit at each level, going down into the sacrum. Did you have a question? Yeah. Yeah. Yeah. Or even worse, I mean, this L5S1 disc is, there's an annular fissure or tear here. I mean, this disc it looks worse on the supine. So they may get a fusion, for example, in the wrong spot. And we'll talk about that. Yeah. Yeah. I believe this is the patient that had bowel and bladder dysfunction. Yeah. This patient was, yeah.
This image here, if you give it to AI of the world's brightest and most Harvard-trained, whatever, it's still going to say that, if I clicker, it's still going to give you the result saying that the alignment looks pretty decent. There's no compression of the paracrine. They call it? It doesn't matter how brilliant you are as a radiologist or whatever computer system you want to use, it's irrelevant if the image is not showing what's really going on with the patient. That's why the weight-bearing positional imaging, the MRI that we were showing you, why this is so critical versus right now in the world, most of the time the MRIs are done in this laying down position. In this position, this is the patient's findings. These images are 10 minutes apart. Completely different diagnosis, completely different treatment plan, compression of the cauda equina, slam dunk in terms of the value of the case. Which see, if you get, and I think...
So we can simulate with physics. We can make it images.
No. If the patient's laying down...
Because of this, because of the pressures. Yeah.
Right? You will simulate correctly that this is what it looks like.
You can't simulate that with physics. Say if this patient standing up, weight, physics, gravity.
You can only do it with, you can only do it with different positions,
No, I'm
right?
saying if you took the person in a real position, computer-wise, you could simulate if the person would stand up with their weight and their anatomy, with gravity, that's the problem, what will happen. You can simulate that condition based upon one normal case.
No, well,
I hope you can.
Well, you're suggesting,
You need a mic. So let's not,
Well-
I think we're going to get off topic.
Testing?
yeah,
The point is asking the question wasn't because I was saying replace the machine. That's not my point. My point is when the machine, the new one, right, gets you in those various positions, right? Now it could be
An infinite number of other possibilities, right? Depending upon weights you're holding, positions you're in. I don't know. I mean, the body moves around in all kinds of positions, right? Would it be value? It's an R&D idea. I'm ideating in my head. Would it be a good idea to take images, maybe 30, 40,000 images in different situations, and then simulate every other possible scenario?
You're 100% right. If we're imaging and it finds that there is tearing of the anterior longitudinal ligament, if it captures that, which it will, because it'll have digital data saying that there is a tear of this ligament. Then, given the weight of the patient, if it's that smart, right, given the weight of the patient, having seen a million other images with the disc degenerative changes, what I'm saying is if you give it enough data points, it will be able to predict, because this is just physics. This is engineering, right? It's the pressure on an airplane wing, how much is the pressure on the airplane, given this simulation, it'll tell you that, and the outcomes of it, right? So,
Answer the question, yes.
NASA does this right now. Okay. NASA uses stable diffusion engines to simulate the impact of the human body in various positions with zero gravity situations. They do it right now. So they take the human body, they do MRIs of the human body, full body MRIs of the human body, numerous ones, before they put them in space. And they simulate that if you're going to defecate in the position, what is the best way to defecate? Because defecation in a zero gravity condition is completely different than defecation with gravity. If you're to urinate, if you're to ingest food, what kinds of solids go through your body? What will the esophagus look like? They simulate the whole human anatomy under all kinds of positions, directions on all three axes, with or without gravity, also with g-forces, because there's also thrust, right, as the rocket ship's taken up, when it's repositioning, vector thrust nozzles are kicking the rocket ship around, the impact of gravity. So they're simulating the whole effect on the human spine, every single vein and artery in your body, with stable diffusion engines. So that's why I was asking, could you simulate, if we could have enough images of the person in here, could we simulate that condition from every possible angle and give it, okay, that might be something to look at. Okay.
The answer is yes. Yes, the answer is yes for listening out there. Okay? If you give it enough data, it'll simulate. If you tell it the pressures, it will simulate. We give the engineering, it will simulate. Right? But we're just not there yet. That's correct. That is absolutely correct. No. Have you not watched Star Trek? Come on, guys. Right? All it is take the simple, they have this little simple device that goes all the body. That's it. When we get there, it's all doable. Scientifically, engineering-wise, Rehan is absolutely right. It's doable. It will be doable, right? We're just not there yet. We just need enough data and a device that can actually capture the data. Enough data, then you can actually simulate and you give the answer pretty readily.
The specific issue with a spondylolisthesis is you don't know, and you don't. A lot of these are fixed. If it's due to degenerative facet disease, for example, it's a fixed spondylolisthesis. So you wouldn't know until you stress this patient. But
no. So let me tell you that. Right. So what happens here in this scenario? If in fact the images that if they get the pixelation and the digital information is showing that there is tearing of the ligaments, which is unstabilizing, or it will then be able to calculate based on that, based on the degeneration of the, if it has enough data, and it has, because we're visualizing, right? It's not visualizing. It's just reading code.
Yeah.
If that code gives us enough information, it'll know that with this kind of a load bearing, with this kind of a patient, this will move back this much. It's just math.
Yeah. I mean, there are individual differences, but this patient, yeah.
One question. What?
Actually, two questions. As Bilal said, in XYZ.
Yeah, as Bilal says, there is enough data. I mean, XYZ plane, what he's recommending. What is the thickness of this size? I believe it's 5 millimeter or 2.5 millimeter, right? What's that?
Most like 3.5 millimeters.
Exactly. So if we can get like three different points, and then we can have a thinner slice, and then we can go the multiple view, and that could be enough. Like I'm talking about thousands of images. I'm saying like maybe hundreds of images, and then we see more thickness slice. Do you think the chances lower to see the error in the report? Or you may define it better like it. So what I'm saying, the thickness go further down. I would say maybe 0.625 to 0.9 millimeter.
You have no good answer.
I don't know.
Yeah, but let me do this. Let you finish your lecture, because otherwise we're going to get lost in the science.
Yeah, I mean, we have the diagnosis here from doing the patient stand. So and now the surgeon knows what to do. So everything else that you guys are talking about is unnecessary. We call it mental masturbation, but I don't know what kind of. But okay. So this patient in particular was misdiagnosed or wasn't diagnosed. So they were presenting with bowel and bladder issues to their doctor. Their doctor was wondering if they were malingering because. The report kept coming back, even if you look back on the images, there's no compression here.
So
quick
So
question.
this patient, when they're standing around, they're losing bowel and bladder function, and for a long time, nobody would pay for it. It was an injury from a motor vehicle collision. Nobody would pay for it. They couldn't get diagnosed, couldn't get properly treated. So, yeah.
At what point in time was he re-imaged, or did you recreate the original images in a digital format?
He had like 3 or 4 MRIs over a span of like 2 years, right? These are done on the same day. So this is done on the same machine, same day.
But was it just recreated, or like reformulated?
No, just scanning the patient again. Standing up and laying down. So different,
With you laying down, you sitting.
and again, the difference being a fourfold.
At what point in time were they able to, I mean, you guys were able to capture it, right? So he went for how many, he had 3, 4 MRIs that were, everything was normal,
Yeah.
until he came to you guys.
Well, not
Right.
demonstrating the actual issue.
No, completely
Yeah.
understood. Like, I mean,
Yeah.
on routine chest x-rays, for example, with kids, hey, everything looks fine, AP, you turn it around, there's a little pneumonia,
Yeah.
pneumonia that's hiding
Yeah.
right behind the heart.
Yeah.
So a lot of times, standard of care, when it's implemented, you can figure that out.
Yep.
For example, in my ER, sometimes just through COVID, now it's just a single view AP and lateral. But I say no. In kids, we got to be a little bit more careful. So in these types of imaging, I mean, do you typically reformat it that way, or I mean, like they miss these routine MRIs eventually till they come to you, and now after all this visits, all these doctors, thousands of dollars
Yeah.
lost already, time.
Well, that's been a lot of what Dr. Khan was doing, I was doing, is educating clinicians on this particular, because again, they'll order an MRI lumbar spine. They don't know where the patient's going.
Are the images that are taken that are later read, are they more comprehensive? Is that what you're asking?
No, which sometimes we order tests, and rightfully so. 99 out of 100 radiologists are probably going to read that. Oh, it looks fine, but that's because they didn't take that particular type of positioning. It was always there. Yeah, it was always there, but you couldn't capture that information because they were taking the wrong position.
That's why it's a false negative.
Yeah,
MRI, right?
yeah.
Look at a couple of slides later, you'll see an even more dramatic slide.
I think a stand-up MRI, not many people are doing. Not the top-notch institutes are doing. So what
No.
you're presenting is like very high-level kind of image, and if there is something error, then
Go to the next slide.
people don't even.
Next one or
Yeah, next one.
previous one?
Yeah, look at this one.
Yeah.
Here, if you look at this slide, check out this slide. No, it's okay. So if you see this slide here, Shema, this story here is really interesting, and I'm taking away some of his thunder, but it's important to
No,
understand.
yeah.
This is a car accident. 3 normal MRIs in this patient. 3 normal prior to coming to us, okay? And if I could see the pointer, what was happening in this case, this patient was here, right? If you look at this here, it's completely normal. Right? The discs are nicely hydrated. 32-year-old patient. Nicely hydrated discs. Alignment looks perfectly fine. There's no compression of the cord. Normal. So he got a normal scan. Got another normal scan. No one was willing to pay after the insurance company denied any more scans. He came and paid cash. But the problem for this patient was he was having his symptoms in this way, and when he would, his chief complaint was that I can't lift my 3-year-old son. Every time he lifted his kid, his neck would go back, and he would feel like dropping the child. It's called Laramie sign. Okay? So we put him in that position, upright, extension, and look what happens. You have 4 levels of disc herniations. You have 3 large disc herniations, multiple levels of spinal cord compression on this patient's spinal stenosis, and you know exactly why this patient is having the problem. If you don't scan the patient in the position that's causing the symptoms, you're going to miss the actual pathology. Common sense is not that common. I've actually stood in front of audiences of 1,000 orthopedic surgeons. Someone would raise their hand and say, wait a minute, didn't you just produce this artificially? Because on the regular MRI, it wasn't there. And I just want to throw my mic at the person, but I don't. That's where being a little patient comes in, right? And I say, doctor, is there compression? Is there a disc herniation, yes or no?
Well, no, you actually produced it by the pressure. I said, is there disc herniation, yes or no? Yes, there is. Oh, but it's in that position. So are you saying that the patient lives laying down their lives? And then you make them look stupid. But you don't make fun of them.
It's like a stress test. Everything's
Yeah.
going to be normal until
Yeah.
you stress enough.
Yeah. Yeah. Yeah.
That's exactly what it's like.
But the idea is symptom-specific imaging. What position is the patient in?
Image them in the position that's causing the symptoms. Otherwise, you may end up with a false negative MRI or false.
Decide that what position that MRI should be done. The clinician seeing the patient or the radiologist doing
The clinician seeing the patient. So we actually ask, what happens is, generally speaking, the clinician sends us an order for a positional MRI, and our technicians will then ask the patient in what position are they having their symptoms, and they'll put them in that position and scan them. So, but it's the doctor's order for a positional MRI. Otherwise, we would do a traditional one, right? So, but we get orders like this all the time. Once I give a lecture or a talk, I mean, after today, you're not going to want to do regular MRIs on musculoskeletal imaging. That's the other problem. It's not available everywhere. No, Houston has it. You have them in Houston. Anyway, I just wanted to make a point that this just changes people's life. Now, the other issue here, the other major issue, well, this guy actually had tears in his eyes after we got done. And I was like, what's the matter? He said, doctor, I can't tell you that even my own family had stopped believing me. Even his family was saying, because of the 3 normal MRIs, there's nothing wrong with you. And psychologically, he was going crazy. Because he said, I knew I had the pain, because the MRIs were normal, no one was believing me. And now everything changes, right? So now the doctor knows what to do, the family is more empathetic, the patient actually has some logical sense about what's going on with it. Yeah.
Dr. Devi, I will let you.
Oh. Do you have that clicker? So yes, we were talking about those levels. We've had a few examples of why that's important and what changes with, and I'll show some more. But everyone knows about failed back syndrome. It's actually a medical condition now. It's so common. And these patients have undergone one or multiple back surgeries, have continued pain or worsening pain, difficulty doing different activities. It's a really sad state, failed back surgery. And there's different causes of it. Sometimes, it can be the patient can have an infection from the surgery, lower percentage from things like that, from complications of the surgery. A lot of them are because of the approach or because other pathology wasn't uncovered. And an example of that is, so you can see here, this patient, this is an upright neutral MRI, the cervical spine. And there's this large disc extrusion here at the C5, C6 level, compressing the cervical spinal cord. There's some abnormal signal in the cord at that level. This patient's at risk for permanent damage, myelomalacia, irreversible damage. So this is something that, a surgeon would need to address pretty acutely. But so this is upright. So this is already accentuated. So this is, 4 times what the pressure at each of these discs would be if the patient was imaged supine. And then this is the patient in extension. You can still see this disc extrusion here, compression. But you can also see this large disc protrusion here that's indenting the cervical cord. There's also another disc protrusion here, less significant, abuts, touches on the cervical spinal cord, but doesn't result in any abnormal signal or compression. This is very useful for the surgeon because the surgical approach that's used is they'll go in, they'll do a discectomy, and then they'll fuse this level. When you take out that much disc, oftentimes they can do microdiscectomy and get back out, but usually with something like this, especially when there's compression, they'll want to fix that level. I'm sorry? Yeah. Yeah, make more room in the central canal here so that that damage can, be halted. But if this, and again, this is upright, so this is already accentuated, this is not supine, but relative. If the surgery is just done at this singular level here, what happens is the weight's distributed, all the stresses are distributed throughout the spine fairly equally. It's more at certain levels depending on lumbar or cervical. But once, you have 7 levels, when you take out 1, you have 6 left. So there's now 6 levels to take that amount of, so there's increased stress at all of the remaining levels. If you have especially the level above with this significant disc protrusion, you're gonna, if the surgeon was to only do this one level, which based on this would be very reasonable, this is gonna degrade really fast and become a problem. This level is gonna start looking like this soon after surgery. So then they're gonna need another surgery. The more surgeries you get, the worse the outcome. So a surgeon wants to know as much as they possibly can before they go in, and you can ask any surgeon. That's because it, yeah.
So the
Yeah.
so the issue here is that if you look at the left side, if the surgeon goes in, they're going to try to make the smallest possible incision, correct? No, I got it. Oh yeah. So I can see it. So if you really look at this, right, it's going to that incision is going to be as small as possible, so the discectomy. The problem is, what Dr. Thier is describing is that if you do that, if you fuse this level, the pressure goes up. Look at this. You're going to have a failed back surgery syndrome, no question about this. Would you ever want to have that happen when you have to go back after 6 months of therapy, 6 months of rehab, you go back and you find this, and now you got to do surgery again on the patient? Infection chances go up, malpractice lawsuits goes up, all the complications go up. So you really want to make sure that you have the full extent of the problem in your, in your understanding, and then what you need to do. So, it's really critical. Again, scan the patients in the position that's causing the symptoms and see what the entire problem looks like, rather than solving this one on the supine scenario.
This is just showing you can use multi-positional imaging. This is a knee and this is a shoulder to accentuate or visualize meniscal tears, cartilage abnormalities. This is the labrum in the shoulder. We don't use multi-positional as much with the extremities. We usually inject contrast, but you can do this, especially in a patient that maybe doesn't want contrast or has some type of reaction. Yeah. Whenever. Yeah.
So Andrew, that means what we are doing in the major medical center, we're not using the stand-up, we're doing this.
Yeah.
Oh my God, right?
Yeah, you're definitely, the literature, you're definitely missing stuff.
I'm missing a lot.
You can't try, and again, you can look back to the history, in a patient that their symptoms aren't dependent on standing position, the utility of a higher field MRI is probably better. You'd want to image that patient on if you have access to a 3 Tesla, it's shorter, the exam is shorter, the image quality is better.
Yep.
You don't really get an advantage. Brains, we always prefer to do on the 3 Tesla or the 1.5. But yeah, if you have a patient who, especially in the back, this is really, really useful in a patient, that you can uncover a lot of pathology. So Yeah, it's very important.
So, you know, I guess the best way to approach this is I think the physicians ordering these tests need to be educated.
Yeah, that's what, I mean,
Because
that's
if
what
the
we've spent a lot
physicians
on,
order
yeah.
this test, they'll order the right test, you'll interpret the right thing.
Yeah,
That's the point. I'm learning this today.
yeah,
After 18 years, I mean, now I'm going to start saying, hey, man, just go to expert MRI.
yeah, yeah, and order the multi-position imaging or state that it's, you know, there's different ways you can do it, but most people don't, it's not available in their area, or they don't even know about it if it is available. So, I mean, so there are some other places that do it, but it's,
Not that I know.
the MRIs are expensive, they set it up, the construction's expensive. Once they have it, that's it. They're not, you know, and they're not going to send a patient out. No medical system is going to send a patient out to use somebody else's MRI.
Maybe we need this technology here in Istanbul too.
That too, there's another problem with this, right? Because it takes us some relearning. This is not your traditional radiology residency where you, right? So for us to be able to do positional imaging, learning, relearning, and people just hate to learn new stuff, generally speaking. So that's why just traditional MRIs are just kind of. Well, I mean, you know, insurance companies are just a whole different animal, right? Because they're, you know, to try to get them to change anything, it's like pulling teeth. Like, basically, an insurance company is going to make sure that even, you know, the doctor knows that you need to do an ablation of the nerve root because that's severe. They're still going to make you go through, you know, 6 weeks of therapy, you know, steroid injection, then PRP and blah, blah, and then finally get to the ablation after 10 months or whatever when the patient is suffering. It's just, yeah, which it does. So,
And why does this all matter? Because human beings won't matter. Machines are going to take over. So why are we going to like images of human beings? Pointless. Let's get some robotic spine.
all right. I'm going to go into this. Now that you're talking about the next topic is going to be AI and radiology and pathology. Yeah. So, you guys want a few minutes break and then come back, or should I? Yeah. Okay, 5-minute break. There's outside coffee. Get yourself refueled, and then.
Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz, uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz, CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesi. MLPK çatısı altında Live Hospital ve Medical Park'la ülkemize ve dünyaya katkı sağlamak için hiç durmadan çalışan, bilimin ışığında dünya ölçeğinde en iyilerden olmayı hedefleyerek emin adımlarla yürüyen ve URAP'ın akademik başarıya göre yaptığı sıralamalarda ilk 10 vakıf üniversitesi arasına girmeyi en erken başaran, hedefleri çok büyük olan bir üniversiteyiz. Çünkü biz geleceğe umutla bakan bir üniversiteyiz. Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesi'yiz. MLPK çatısı altında Live Hospital ve Medical Park'la ülkemize ve dünyaya katkı sağlamak için hiç durmadan çalışan, bilimin ışığında dünya ölçeğinde en iyilerden olmayı hedefleyerek emin adımlarla yürüyen ve URAP'ın akademik başarıya göre yaptığı sıralamalarda ilk 10 vakıf üniversitesi arasına girmeyi en erken başaran, hedefleri çok büyük olan bir üniversiteyiz. Çünkü biz geleceğe umutla bakan bir üniversiteyiz. Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesi. MLPK çatısı altında IM Hospital ve Medical Park'la ülkemize ve dünyaya katkı sağlamak için hiç durmadan çalışan, bilimin ışığında dünya ölçeğinde en iyilerden olmayı hedefleyerek emin adımlarla yürüyen ve URAP'ın akademik başarıya göre yaptığı sıralamalarda ilk 10 vakıf üniversitesi arasına girmeyi en erken başaran, hedefleri çok büyük olan bir üniversiteyiz. Çünkü biz geleceğe umutla bakan bir üniversiteyiz. Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesiyiz. MLPK çatısı altında IM Hospital ve Medical Park'la ülkemize ve dünyaya katkı sağlamak için hiç durmadan çalışan, bilimin ışığında dünya ölçeğinde en iyilerden olmayı hedefleyerek emin adımlarla yürüyen ve URAP'ın akademik başarıya göre yaptığı sıralamalarda ilk 10 vakıf üniversitesi arasına girmeyi en erken başaran, hedefleri çok büyük olan bir üniversiteyiz. Çünkü biz geleceğe umutla bakan bir üniversiteyiz. Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesi. MLPK çatısı altında Live Hospital ve Medical Park'la ülkemize ve dünyaya katkı sağlamak için hiç durmadan çalışan, bilimin ışığında dünya ölçeğinde en iyilerden olmayı hedefleyerek emin adımlarla yürüyen ve URAP'ın akademik başarıya göre yaptığı sıralamalarda ilk 10 vakıf üniversitesi arasına girmeyi en erken başaran, hedefleri çok büyük olan bir üniversiteyiz. Çünkü biz geleceğe umutla bakan bir üniversiteyiz. Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesi. MLPK çatısı altında Live Hospital ve Medical Park'la ülkemize ve dünyaya katkı sağlamak için hiç durmadan çalışan, bilimin ışığında dünya ölçeğinde en iyilerden olmayı hedefleyerek emin adımlarla yürüyen ve URAP'ın akademik başarıya göre yaptığı sıralamalarda ilk 10 vakıf üniversitesi arasına girmeyi en erken başaran, hedefleri çok büyük olan bir üniversiteyiz. Çünkü biz geleceğe umutla bakan bir üniversiteyiz. Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesi. MLPK çatısı altında Live Hospital ve Medical Park'la ülkemize ve dünyaya katkı sağlamak için hiç durmadan çalışan, bilimin ışığında dünya ölçeğinde en iyilerden olmayı hedefleyerek emin adımlarla yürüyen ve URAP'ın akademik başarıya göre yaptığı sıralamalarda ilk 10 vakıf üniversitesi arasına girmeyi en erken başaran, hedefleri çok büyük olan bir üniversiteyiz. Çünkü biz geleceğe umutla bakan bir üniversiteyiz. Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz, CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesiyiz. MLPK çatısı altında Live Hospital ve Medical Park'la ülkemize ve dünyaya katkı sağlamak için hiç durmadan çalışan, bilimin ışığında dünya ölçeğinde en iyilerden olmayı hedefleyerek emin adımlarla yürüyen ve URAP'ın akademik başarıya göre yaptığı sıralamalarda ilk 10 vakıf üniversitesi arasına girmeyi en erken başaran, hedefleri çok büyük olan bir üniversiteyiz. Çünkü biz geleceğe umutla bakan bir üniversiteyiz. Biz İstinye Üniversitesi'yiz. İstanbul'un merkezinde, hayatın içindeyiz. Öğrencilerine değer katan, hep en iyisi için çalışan bir aileyiz. Teknoloji, sanat, yapay zeka ve dijitalleşmeyi kapsayan öğrenme ortamıyla eğitim verdiğimiz öğrencilerimizin hayallerini gerçekleştirdiği adresiz. Biz uluslararası projelerle dünyanın her yerinden gelen, dünyanın her yerine giden öğrencilerimizle, Erasmus değişim programlarımızla ve dünya üniversiteleriyle yaptığımız akademik anlaşmalarla her yerdeyiz. Biz engel tanımayız. Çünkü biz engelleri aşmayı iyi biliriz. Biz bugünüz, biz yarınız. Halk sağlığını iyileştirmeyi ilke edinmiş, sürdürülebilir üretim ve tüketim alışkanlıkları geliştirmeyi teşvik eden uygulamalı projeler ve sıfır karbon hedefiyle temiz bir gelecek için varız. Biz, CERN Atlas Derneği'nin Türkiye'deki 3 üyesi arasında yer alan tek vakıf üniversitesiyiz. İSİTEK ve İstinye Garaj gibi Ar-Ge ve girişimcilik merkezlerine sahip, 100'e yakın proje ve 100'den fazla girişimci öğretim üyesi ve mezun şirketiyle hızla büyüyen İstinye Üniversitesi. Emel
I actually want to talk to you guys a little bit about what's happening in radiology today and how artificial intelligence, or AGI, I should say, artificial general intelligence, is going to change radiology. Now, for those of you that have known me for a long time, know that I've been talking about this particular subject for how long? Like, that AI is coming, be ready. Whoever's in the forefront, you'll succeed. Whoever does not adapt is going to become extinct. I know that's a big statement, but it's true, especially in radiology and pathology, as I'm going to talk about. Okay, so what do we do as radiologists? What do we do? What's the basic thing that we do as radiologists? Basically, we are looking at digital information and pattern recognition. Right, Dr. Thierry? Correct? Abid, that's what we do all day, right? We have digital information and pattern recognition. Therefore, why will machine not learn that? Right? And then when we talk about we're looking at images, reading images, looking at AI actually will not be reading anything, or actually not be looking at anything. It simply reads code. And there's no way that the human eye is going to get to the point where we can see as deep as code, as the digital information in the movie Matrix. You know how those digits, those codes are going up and down? So therefore, given enough information, given enough experience, it will far outcompete the radiologist. So I've made it my little bit of my life mission now to at least those young ones in our community that are graduating and finishing their radiology residencies or fellowships, and a young one sitting right over here right now, right, as an example of teaching them how to run the business of radiology, how to actually own a clinic and run a clinic and what's needed to be done, because the radiology centers are still going to be needed. The radiologists themselves may not have to do as much work, but the legislations and all that stuff is going to keep us around for quite a while. So doctors aren't going away anytime soon, but you will not be in a partnership track. If any of you young ones are thinking of going to radiology or any other field for that matter, just know one thing. If you don't understand, if you don't capture this stuff, you don't really attach yourself to AI, you're not going to be able to practice very much at all. I'm serious. You know, so this is something very important. For us as radiologists, there's no partnership tracks anymore. You will not become a partner in any, because the partners are going to realize that they'll be able to do 4 times more output of work than before. Why make somebody into a partner? Right? And sooner or later, you're not going to have jobs. So why is that? Why am I saying all this stuff? And why have I been saying this for the last probably 5 or 6 years? And I've had a lot of naysayers and pushbacks, a lot, except now it's becoming much more real. So with digital information, with what AI gets, it'll actually have enhanced diagnostic accuracy and speed, okay? Automated image analysis, we already have this, okay? Now, when Bilal sits there and takes a picture and starts reading something to you, that's extremely rudimentary. And you may actually push back and say, hey, wait a minute, that's not, this image is showing this, this, and that, but what he's doing is taking a simple camera, taking a simple picture off of PowerPoint, low resolution, and it's still saying, hey, at least I recognize that this is the spine. I recognize there's a disc desiccation at these levels. I recognize. Cardiac. So I say, so it even at that level, that rudimentary level, is giving you these kind of reading. Now, as I said to him before, you read off something like that, 50, 80% of the time, I'm going to say, hey, no, I'm going to push back. But that's not what he's doing. He's just giving a demonstration of saying even with this rudimentary level, we detected 50% or higher accuracy, right? Anyway, so AGI can rapidly process vast amount of imaging data, detecting subtle abnormalities down to the level of the code, right? And it'll capture early stage tumors. Before my eye can see it, it will read the code of a tumor. It will know that this is liver cancer because of the code it reads, not because of what it's seeing. Are you guys following? Stop me if you don't understand this. This is very important to get. Okay? For those of you out there, I'm so sorry. I'm just seeing one of my best friends getting massaged by one of my best friends. I just saw your expression on your face, and yeah, I'm sorry. I started laughing. I just couldn't help it. Okay, all right. That's why you're not asking any questions. That's right. That's right. Yeah. All right. Okay, so look, so okay, all right. Early stage tumors, small fractures. Believe it or not, we actually miss a lot of fractures in radiology. It's surprising, shocking. The number is about like 58% of these small fractures are actually missed. 58%. That's a pretty high number.
Are X-rays better for fractures?
And what's that?
X-rays are better than MRI for fractures?
No, I'm not saying that. What I'm saying is generally like a patient typically doesn't even get to an MRI, especially if you have a linear, small, very thin fracture. It's going to heal on its own, but it is missed. And that is a cause of pain for that patient, but it's not, it just hasn't been seen. So we'll capture that in this. This will be digital X-rays, very likely, highly likely. So everything is now digital. We have X-rays are digital, ultrasounds are digital, or CTs, everything is digital information now. So small fractures, minute changes in tissue density, right? That may be missed by human radiologists. Now this is also quite interesting and it's very valuable, multimodal data integration. What this means is actually that AGI and AI actually is going to pick up other modalities, other images that was done, and clinical data, and lab results, and patient history. What happens for us, generally speaking, is that I will get a prescription from a doctor to do a lumbar spine MRI, and it says back pain indication. Right? I mean, right, that's what I get. Right, Dr. Rahman? That's not in your cancer cases, probably have a lot more data, but at least for us, ER doctors writing back pain, you know, headache, do a brain MRI. I mean, so we don't get a lot of information. So what, in terms of AI and integration and systems that are integrated, it's going to know clinical data, it's going to know lab results, patient history, and to put all of that together along with the imaging to actually give you a diagnosis. I think that will be much far better than otherwise, right? Even as Dr. Theory was talking about earlier, right? When we actually have clinical data, we're able to give better diagnosis. Like you said, right? You can actually drill down and say, aha, this is what's happening with the patient when the doctor tells you that there is right lower quadrant pain, right? So we're thinking, okay, I better look down there a little more closely at the potential appendicitis the patient may have, right? So that's very important. So prognostic modeling. So AGI can actually predict disease progression, treatment response, and patient outcomes by actually analyzing the imaging findings in conjunction with clinical data, such as genetic information, demographics, and patient history. The more information that's available, even us as humans, we're able to give you better diagnosis and also give you better prognosis. Actually tell you, based on history and our studies and the research, okay, this is what we're expecting in the future on this patient, okay? But we don't do that with every patient. It will, or she will, or he will. I don't know how Bilal wants to call it that, right?
I have a question, Sanaway. So this is very important.
Yeah.
say AGI can predict the disease progression. So that means if we have a 3 scan, the AGI can define the difference, right?
Yeah.
Wow.
Yeah. Because it's going to have data on every, so it's going to, even with your own practice, Dr. Rahman, is going to remember all your patients and all the clinical findings and the lab results. Some things you and I just can't do.
Right. Right.
But it's going to have it, and it's going to be able to analyze it continuously.
So it's like a doctor, sorry, it's like a patient. I'm a patient, and you are a doctor. Sorry, I'm AGI, and you are a doctor, and Bilal is a patient. So basically, you are getting information from 2 different systems. The accuracy is very high.
Yeah.
So what is happening? You are asking, you open the system and you say, okay, the AGI, could you tell me the disease progression on scan this date, is that, this date? And AGI say, oh yeah, this date, this one, this one, this one. And automatically you can make a decision. Oh, okay, so then you go for the therapeutic as well. Is that right?
So it's going to look at not just your own patient data, it's going to look at the data from not only your imaging, it's looking at all the other aspects of the imaging, but it's not just doing that, it's actually also looking at the world out there, right? When somebody has this lab results, and somebody has this genetics, and somebody has this imaging finding.
So it integrates everything. So you are getting, like, connecting just like pancreatic cancer.
And what happened to those 1 million patients?
Oh, got it. Okay. That's amazing.
Is that going to exactly happen to you? Maybe not, but you may be that 1 out of 1 million that it doesn't happen to. But out of that million, when
That's the difference between AI and
GI, yes.
I'll talk about it in the next slide. So the causality between one issue and something else is the G, generally intelligent across everything.
Oh, okay.
Versus where narrow AI, narrow AI will give you a diagnosis on just what you see and it won't tell you anything else. But a GI will do a diagnosis of this and say, like I just did, right? It did the diagnosis on the spine and it said, you're most probably suffering bowel and bladder issues. How did it know that? It didn't just look at it and give me a diagnosis and say, there's a problem here and goodbye. It said, there's a problem here and you're most probably having bladder issues. What is it doing? It's basically looking at something, reading it like a radiologist, and predicting what the patient's probably saying, and saying to you that if those symptoms exist, then do this treatment. AI won't do that, AGI will do. That was a great example of the general intelligence of AGI versus just AI.
Yeah.
Data analysis versus data analysis.
So we have 5 MRIs in MRI. Let's say MRI number 2, 3, 4, 5. We have a 6 MRI, 7 a CT scan, and 40 labs and 45 visits. And we ask question, the AGI will give the consolidated from everything. Like, this is what we have. That's amazing.
But it's not just, but it's with millions of data points.
Millions, yeah, exactly.
Right? So it's not even the 5 data points or the 40 data points, millions. In the case of you, Bilal, in that scenario, the clinical history would have already told it that the patient is having difficulty with urination. It would already known that. And gone.
We already know this. Let's take it next level. What else could be happening?
Prognosis. It would go to the prognosis part. It'll give you that. Now, Rehan made a good point. He said, wait a minute, you're giving way more information than a radiologist typically does. They don't go into any of that stuff. The reason we don't go into all of that stuff is because we don't have that data. No. We don't have data. Radiologists do not get data. That's the problem. Nobody tells us anything. The doctor will simply send us a referral with just one line or one sentence or one word. Okay? We don't know what happened to the patient. We don't know what the pathology of the patient is.
A lot of guesses.
So the thing is...
No, that's not their job to guess.
No, stop. That's not the point. The point is not... The reason that it's not our job to get is because that's how we kind of pigeonholed ourselves because of the fact that we couldn't do our job. If you say to me as a doctor... Okay, can I fall back a little bit? So the issue is going to be this. We are probably not going to need these highly specialized specialists anymore. Okay? You're not going to need a radiologist anymore. You can be the family practice physician, you can be the internal medicine doctor, and you're not going to need that person because that imaging is going to basically be done by AGI. The diagnosis will be done by AGI.
And it's going to give you all the information that you as a doctor, you won't even need a radiologist in the middle. The reason I'm telling the radiologist to own imaging centers is because imaging has to be done someplace. And very likely the legislation will keep it in that so the radiologists can actually run imaging centers. We don't need a radiologist in this scenario, Rehan, is what I'm saying.
So what you're saying, service provider and doctor.
Yeah. All I'm saying is that you're going to need, I believe that you're still going to have, at this point in time, human doctors. What I'm saying is that you're not going to need to go this specialty, the radiologist or pathologist and all kind of that.
Can do the job of the oncologist, the nephrologist, the endocrinologist, the radiologist, so you can have one physician now that doesn't need to go through this whole process of referral, didn't get the MRI, got the MRI, blah, blah. One person can sit there and say, let me treat this patient holistically, please, at a push of a button. And that $500 you're paying, or the insurance company's paying for me, you're getting the job of every possible physician that may have cost $100,000 of the insurance company probably would have been rejected, you never would have had that treatment. Just come to me. I'll do that one MRI, and the cost of MRI is going to be lower, because obviously the radiologist is not reading it, right? And I'll do that one extra, whatever I need, and I'll do the whole scan for you, and I'm going to use my clinical knowledge, and I'm going to diagnose you. And you won't have to go anywhere else. And
You're
that
gonna
patient who was suffering with that back problem had to come back 2 or 3 years later, that would have been addressed day one.
You're going to get pushback. You're going to have people telling you, no way, get out of here. What are you talking about? What's wrong with you, Dr. Sana? 5 years ago I was being told this. Today I'm not being told that. But I'm telling you 5 years from now, you're not going to need the specialist.
So talking about you saying that the doctors don't give enough information, just back pain, but there is a whole HPI also.
Hold on one second. Can I have the Shema?
There is a whole HPI on that patient, history of present illness. So doesn't the AI would read all that HPI?
That's right. That's right.
So
it will
then
know.
The doctor is giving enough information.
Today's world, they're not giving me anything, but AI is going to have access into that system where you don't even give it, it'll know it.
Okay.
For me, I can still do it, but
Right,
it takes,
right.
am I going to take my time in the middle of my day with the 500 studies I'm trying to figure out to go and find your patient's HPI? History of present illness?
Yes.
I'm not going to, it's a time issue. I would give you a better diagnosis if I had that HPI, but I don't have time to go search for that HPI. But I would give you a better diagnosis if I had it.
Right.
Rehan?
Is there any examples that you could provide where prognostic modeling would be a bad idea?
Oh, great question. Thank you. That's, every now and then you come up with one. So he's asking, is there an example where a prognostic model would be a bad idea? Okay. It happens all the time, Rehan. All the time. Where a cancer doctor will come and tell you that you got this kind of a cancer and you got 2 months to live, right? Right? Prognosis, except the patient lives for 3 weeks. Sometimes 2 years. Okay? You know the reason why that's bad? Because they will take some number. When somebody finds out that they have cancer, you'll find that they will go down way faster. Within a few weeks, they're gone. Because the body will actually shut down because of the prognosis.
That's exactly what I was getting at.
Yep.
You guys are pretty self-fulfilling prophecy.
No, it's not that. Don't look at it like that in that sense, right? Because I'm talking about saying, let's just say that you've got some genetic issue that gets identified way before, right? Prognosis. That if you don't treat yourself, if you don't take care of yourself, the data says that you may end up here. You're not there, right? You may not have cancer, but you have that gene. So guess what? It's better if you have your mammogram done, not your mammogram. Okay? Sometimes men need it too. But I'm just saying that somebody may then actually also start to do mammograms every 6 months instead of every 2 years, right? Henceforth, potentially saving their life by identifying that. So it's all about how really you use what information. The evil use. He's asking about the evil use. Let's talk about this. I'm talking about the world out there. Yeah.
Here we have an insurance company that's using this modeling, right?
That's where I'm going, right? That's where let's look at an insurance carrier, okay? they're going to use this great modeling that you guys have created to say, well, the 95% chances that this patient is going to die. So the 5% chance to save them, it's not worth the investment. And you guys are giving the ammunition with prognostic, not you guys, but prognostic modeling has given them the ammunition to further limit hope or the outcome that is unlikely.
Yeah, so I cannot make my life decision. No, let me, this is a very important ethical question here. I do not make my life decisions based on what the insurance companies like or don't like, right? If I'm going to be able to do some prognosis that actually help you save your life or your child's life or the potential, some harmful event in their life in the future, I don't care what the insurance company thinks, doesn't think, Rehan. It's going to let that stuff pan itself out. But we have got to provide the best possible, with a good heart and a good mind and a good soul, the research on this stuff is possible. Okay, so look, somebody asked me the other day that, hey, is AI going to kill us? All right, we talked about this. Is it going to destroy us? Is it going to actually, Terminator or Matrix? Do you guys ever think about that? I mean, I'm assuming if you guys are thinking AI, you're thinking in those terms, right? My answer is this: it might. But as long as I have the ability to do something good with it, I'm going to do it even if it's one day more that it can do it, or a year more, or 100 years more. And it goes back to a hadith from the Prophet ﷺ, right? When he said that if the day of judgment is starting, if it's starting, you see it that it's starting, and that the sky has burst open, and you're planting a tree, he says, finish planting that tree. Right? Why? Just keep doing good with what we have. And I know it's the devil's advocate and all this stuff, the insurance companies, I just don't want to get stuck in that discussion.
No, I totally agree with you. In fact, I think our protection from AI will come from AI.
That's right.
We need to build AIs that are programmed to protect human beings. And that's what we need to do. We need to leverage AI for good.
Yeah.
Thank you, guys. Harms and benefits.
Give me back that microphone. Yeah.
Talk about prognostic modeling for a second. I want to speak to this point real quick.
Yeah.
So you brought an ethical issue. I just gave a talk on oncology about, I helped some really advanced cancer research people on FDA clinical trials for some new gene therapy, basically, these guys are working on, right? Now, let's go the route. The fundamental thought that you posited just now was, if we know the outcome, will we not cause that to happen by sharing that information, basically causing like the negative placebo effect to happen to bring the person backwards? Okay, think about this for a second. Let's take cancer. We discover cancer, we poison the patient. Chemo. Doesn't work, we burn him, radiation. That doesn't work, we take a knife to them, chop it out. Look how primitive we are. Poison him, burn him, chop it. So now, we get the prognosis, we don't tell him, we poison him, burn him, and chop it. Again and again and again. And the toxicity levels are so high for the poison and the burning that they're going to die because the side effects, not the damn cancer. You die from the side effects, you don't die from the cancer. Did you know that? It's so toxic, you die from the side effects, not the cancer. The cancer probably might keep you going for 20 years. It's the toxicity levels of the treatment that kills you, not the cancer itself. Now, I ask you an ethical question. Should I not do prognosis modeling and know that I have a predisposition to particular cancer, and then be that next person in phase 3 clinical trials that subjects myself to the epitopes to help discover that new gene therapy that might be able to cure me from the cancer because I now know about it? Or would you rather be burned, poisoned, and chopped out?
Well, you're using a very specific model.
Well, no, the logic's the same.
What if you tell a patient that there's a good chance in the next month that 99% chance is going to die? Okay? You use the word placebo, negative placebo. No, it's this. Okay? There's plenty of studies that show that you cannot reference in your scenario where hope is destroyed by this negative.
Agreed.
And hope then does what?
Agreed, but this isn't...
Let me finish. Hope kills the immune system. The very immune system that's attacking cancer, you have destroyed
if I may.
One.
Right, give you one scenario where, yes, there is a lot of patients that die.
Don't live with one scenario. Don't live with one offset. Let's try to do as much possibly good with the prognostic tools that we have in terms of saving lives and in terms of predicting.
I'm
Right.
fully in favor of what you guys are leveraging with this in terms of prognostic modeling. It's how it's used in different scenarios. I wasn't saying that his scenario is right and my scenario is right.
Right.
I was giving an alternative to his one scenario. There's another scenario where
So you're right. I mean, I've seen this in my life. I've seen people when they get news that they have cancer, they just go down the tubes, okay? And then we have a cancer doctor standing here. But
What you're mixing radiology. When you're sending the images to radio, I'm talking about the diagnostic, prognostic, based on, this is a very hot topic in tumor board. When we see patient in the tumor board, everyone is there. Urologists, medical oncologists, radiation oncologists, IR guy, everyone. Nothing is stopped. What this system is saying, this system defines the tumor based on the follow-up imaging. And let's say if there is a hepatocellular carcinoma, the system will define the measurement based on whatever is in the report. The system is actually saying there were 5 follow-up imaging, there were 6 MRI, and based on the start, as Sanav mentioned, till now, the tumor shrinking, or tumor is getting better, or tumor is going down. And actually it was heterogeneous, and from heterogeneous the enhancement pattern and everything went down, and all the values what we have is down now. So that is what I see the prognostic. That's what I see the progression of the disease or regression of the disease. 2 point, right?
yeah, but I think if you get stuck in the specifics, it's too. We live our life on prognosis.
Exactly. I was just going to say that.
All of our lives prognosis, right? You go to medical school, what's the prognosis? You're going to become a doctor, what's the prognosis? You'll get a job. Your prognosis is you have a job for the rest of your life. Your prognosis is you're going to make some decent amount of money. That's all prognosis. Yeah. But why? It's based on information, data that we've gathered over the years and whatnot, and so it can be used for good. Now, she could look at this and say, well, you know what, if I go into psychology or if I become a dentist, my prognosis is I'm going to commit suicide more than any other doctor in the field. It's prognosis. Why? Because that's what the data shows us. Most dentists have the highest rate of suicide, in the US at least. And I can see why. You look at somebody's mouth all day long, like, what are you doing? But so I don't want to get stuck too much in this, but my point being is everything is a prognosis, right? So we can, and anything and everything on this planet you can use for good or bad. Okay? You can pray Salah and you could be bad. How's that? You say, you know what, instead of praying 3 Rakat Maghrib, I'm going to pray 4 Rakat Maghrib because I want to do better. What happens? Right. Everything is good or bad.
It's only a matter of time, okay? It's only a matter of time before this prognostic modeling is out of the realm of the physicians and it's in your hand. I saw an example of an Illumina machine, okay, do a gene sequence, a full sequence, end-to-end sequence in 10 hours. 10 hours. And that's Illumina, okay? It's a $500,000 machine. They just showed it to me at Dr. Amir Essen's lab, okay? 10 hours, bam, sequence the whole genome. They're getting it down and down and down. Pretty soon, you'll be able to sequence the human genome. Google's working on it right now. I had a tour of the quantum labs last summer. They can sequence the human genome in 3 seconds on a quantum computer. But the heat's too much right now, so it's not commercial. It's a matter of time before my wife and you and I will know if we're going to die of brain cancer. It's just a matter of time. So this whole ethics thing about messaging the negative of somebody, it's beyond our control. Just in gene sequencing alone, they're going to figure it out, whether or not you're going to die and by when. The ethics of this lies in the physician's hands. That's why he said, right, the physician's always going to be there, the professor's always going to be there, the lawyer's always going to be there. The modeling is going to be in his hands or your hands, and you're going to determine if the patient can and cannot handle it. That's where the empathy comes in, the emotion comes in. That's where where you are human. And you don't tell a child you're going to die. Maybe you tell somebody, you got 6 months left to live, better wind up your affairs, So that's a decision. It's a subjective, emotional decision. This is a medical conference, and we're talking science here, right? In science, you can't argue the prognostic modeling. Does the physician need that in his hands or her hands? Of course. And if they don't, it's going to be in the human's hand with genome sequencing anyway. DNA sequencing. So it's a matter of, are we leveraging the best science, right, to make the best decision? And then the communicator of that, you know, I don't have much empathy, so maybe if I was the oncologist, I'm like, but you got 3 weeks left, man. I'm sorry to tell you, better go get your, make sure your life insurance policy. Maybe you were more empathetic. Maybe you, that's up to you. But the modeling is the modeling. We need the modeling.
All right. So in terms of continuing with AGI, in terms of radiology, right? Talk about automated routine tasks. AGI can actually automate tasks as imaging labeling, measurements, report generation, reducing time, efforts required by the radiologist. You'd be surprised as to how useful these measurements are to the doctors, especially the orthopedic surgeons and whatnot. They're, you know, I don't know if you've seen the orthopods, I don't know if you do in the ER or not. They're constantly standing there with a ruler, protractor, measuring angles and trying to look at the. Why do they do that? Because it actually has some value, prognostic value, for surgery, not surgery, right? But who should really do it, right? It should be the radiologist that actually does that work. But we don't, because if we're going to sit there with every image and start doing these measurements, then we're going to be broke, right? So we don't do it. But AI will actually automate all those measurements, okay? Report generation, of course, that's already happening, and reduce time required by the radiologist. Now, this is really interesting when I was reading this part, right? So real-time imaging triage, where the radiology, where AGI can prioritize, and this is something for you, pretty important, like you're talking about this yesterday in ER, you need to prioritize, right? Which patient gets seen earliest, and what's the, you know, urgency or emergency in which type of patients, right? You'll move those patients up and down based on that. So it'll actually do that for you. The other thing that was really, from your talk, that was mind-boggling to me, was your statement about how long it takes for you to get results back from the imaging, right? And you're trying to make decisions within seconds and minutes, and the imaging results are coming back in hours. Right? Or days. Yeah.
So, for example, if I have a child.
Wait, hold on one second, because there's people listening up in there, they're having trouble with it.
So a real live example of this would be if I have a patient that comes to the emergency department that in my institution, CT is the imaging modality to diagnose appendicitis. We get this done. So based on those facts, the patient goes to CT, gets it done, then how long is it going to take for the radiologist to read it? So that may depend upon how many films are needing in line to be read, time of day, a lot of different things. Based on these findings, we might have to call the surgeon who needs to take the appendix out at 3 o'clock in the morning if the patient presents at 3 o'clock in the afternoon. So that's 12 hours till we finally get this diagnosis. Now we're giving antibiotics, where it could have been done in hours.
Wow.
And the doctors actually during awake hours, during business hours.
Yeah.
We're not calling the doctor at 3 o'clock in the morning.
Yeah.
So
yeah. What about cholecystitis, right? I mean.
Exactly. All these things, time saving.
Time is critical. Yeah. So AGI will definitely help you in terms of real-time imaging, real-time image diagnosis coming to you as you do it. So, I mean, and of course in the ER, you're looking at a variety of different things, especially with accident system. I'm talking about brain hemorrhage, you know, PE, of course, fractures. All of this is going to be at the tip of your finger, ready to go. So, so in terms of enhanced radiologist training and education, I think that, you know, the radiologists now, at least we're going to be able to have diverse clinical scenarios. With AGI in place, you can actually simulate. This is something back to what you were talking about. We can actually simulate things now, right? With AGI, we'll be able to simulate for them different kinds of conditions, complex problems, and hopefully getting the radiologist to hone in on the diagnostic skills within controlled environments. We actually don't have that right now. We just try to use old cases and try to find out, okay, what case looks like what, and that's how we've trained in the past. But it'll actually be able to basically give us, my guess is for any kind of simulation, for any kind of disease, right? So, rare pathologies, again, this is something that really bothers us a lot as radiologists, because it's hard to keep up with, or keep those rare things in mind, right? Is, you know, and zebras are, yeah, the problem in the U.S., which is hopefully not the same as the problems you guys have here in Turkey, the problem we have is that we have consequences to everything. Like if there's a missed finding, whether it's, you know, 1 out of 1,000 studies, no one's going to say you were pretty good on the 999, right? We get sued readily in that country. Lawyers are always waiting to do so. You know, if I'm reading out 100 or 120 studies in a day, you know, in that month, I'm talking about 3,000 studies. A 1 out of 1,000 missed rate, still 3 studies missed, right? So I actually have in my practice, in my business, we have 3 levels of check of diagnoses on each case. So real-time feedback, this is actually also going to be nice in terms of radiologist training, where they'll be able to do the simulations and get immediate feedback on their findings. Now, what's interesting about this is something that you guys probably missed from my earlier talk, is that it will learn how you learn, okay? It, meaning AGI, would learn how you learn, and then as you learn something faster in a certain way, that's how it's going to start teaching you. And it'll get better at teaching you, and you get better at learning. So it'll get better and better and better at teaching you that particular subject matter, okay? And it'll be very personalized to you. So real-time feedback, real-time teaching, and continuous improvement. Scalable radiology services, and this is actually one of the things that's really cool for us, like in terms of owning imaging centers, because I've had people say, well, are you going to let go of your radiologist? I'm like, why would I do that? As we implement this, I'm just going to increase my business, right? Because in the US, you still need the radiologist to sign off on reports. We still have legislative mandates and everything else. So why would I let go? Why not just increase and outcompete everybody in the country with our abilities of scalability, right? This basically leaves to a whole bunch of things, right? You have basically remote radiology services. We can service pretty much anywhere on the planet, to be honest. Routine interpretation management by AGI, reduction in radiology staffing overhead that's needed, expansion of radiology access in underserved areas. You know, and this is worldwide, so we could provide imaging diagnoses, you know, like I say, in Laos and Los Angeles, same level of diagnosis. Now, this other issue is a big one here in terms of underserved areas. So I actually wanted to do some outsourcing in Pakistan for radiologists to do preliminary reads, and had a horrible experience, okay? What I meant is when they were to do preliminary reads, we would look at it and make sure that it read okay, and then you know, try to make our system more efficient. What I found was there were so many mistakes. We had to keep redoing reports over and over again. And these are board-certified radiologists in Pakistan that were also trained in England and all that stuff. Okay? So, yeah, you're right. Well, I'll tell you why are Pakistani radiologists making mistakes on MRI? They're not so bad in X-rays, and CT is even not bad. I think it had a lot to do with just the availability of the technology on which they could learn. So there's a lot, yeah, so a lot less experience on MRIs.
How did they achieve board certification if they were inexperienced?
Not US board certification, Pakistani board certification. Yeah, yeah. So my point in this is this: how many missed, and this is, you know, Monis, the neurologist, Said Monis? Yeah. So the real life, this is just a few months ago, his mother goes to Pakistan for a visit, gets a stroke, ends up at Aga Khan Medical Center. And Aga Khan is supposedly one of the best hospitals in Pakistan. And he immediately flies over there, calls me when he's there, he goes, son, I need to send you some images, because as far as I'm concerned, as a neurologist, I'm reading these MRI images, and these guys are completely mistreating my patients. They misdiagnosed her and mistreated her, okay? So he sent the images, I saw it, and I was like, yeah, this is, you know, so she actually had some subtle, but she had hemorrhage, right, in different areas of the brain. And he was just shocked at the it was just shocking, the kind of treatment that his mom was getting, and he had to go there and yell and scream and try to get things to change until it got fixed. My point being is that there's a huge disparity in the world in medical care. This, especially with underserved areas, AGI is going to equalize that.
Can I add that point?
Yeah.
Dr. Eric Schultz actually explained this really well. Okay. Your question, why in Pakistan, right? He said it's fair. Here's another reason. In the United States,
Or more advanced nations, right, where the laws are tighter, there's accountability. So let's use Dr. Eric Schultz's example of an abdominal, I think it was a scan, right? He said in America, we're taught to read from here, down to here, left to right, down, back up. You got to read it that way. There's no other way to do it. And the structured reports are designed in such a way when you keep punching the information, it has to be that way, okay? And if you go against it, your license is on the line. You may lose license, potentially, right? That 1 out of 1,000, you lose your license. In Pakistan, for example, they're not as regimented, okay? So do they know how to read the image? I'm sure they do. But the mechanism in which they go by it is loose. The accountability for not following the rules is loose. And malpractice is not a big deal. So in time, people become more loosey-goosey with whatever they do. And you'll see that in everything. You'll see that in engineering of buildings. Very loosey-goosey with electrical wiring. Not so much in America. Very loosey-goosey with plumbing. Not so much America. Very loosey-goosey, as I imagine, in a university reading an MRI. Not so much America. So are they any less skilled than we are? No. It's just the checks and balances on them are not as stringent as is on us over here. So as a result, the quality is not as high as what we're coming here. That's my opinion. AGI won't make that mistake. Doesn't matter where it is in the world, right? There's no loosey-goosey. It's going to do it the same way every single time with precision, no matter where in the world they're using it.
Oh, for sure. With consequences. Consequences are what makes us better. Yeah, and I'll tell you one thing. It's very simple, right? You see the same doctors coming from Pakistan, coming to the U.S., getting board certified, going to the become some of the best doctors in the country, right? Same doctors, same people, same intelligence. There's just the best, some of the best. You have NASA engineers. How many are there Pakistanis? Huge.
Let's take that matter and apply it to AI for a second, right? AI in the it's trying to save cycle. Yeah, go ahead.
Can you do it? Oh no, I trust him more.
Okay, so here I am, I'm AI. I'm just hypothetically AI. I'm like saying, look, everything's compute. It's a number of cycles in a processor to get this done, right? But I find a more efficient way to do it. I'm constantly modeling my own self, remodeling my own self to become more and more efficient. Since AI doesn't have an accountability for accuracy, how do you say, well, no matter what you do and whatever change you have to do, you're going to put a marker, say you have to be at 95% accuracy. But to keep that accuracy level, when you originally tested it, you tested against radiologists, and you said, okay, you're 95% accurate. You're 100% accurate. You're better than radiologists. But now it's constantly getting better and better and more efficient to save cycles. Maybe in a third world country, they don't have an NVIDIA cluster or whatever, right? They have weaker processing. So it has to use what it has in terms of compute. So here we have it, and it's doing this, and it's remodeling itself, and it's advancing itself, all right? Where's the check balance against its accuracy? Is it going to have its old model and then check again? It makes sense to me. I have the old model. Hey, where's my model when I was tracking against the radiologist? I was at 99%, and now I'm going to track it against this. But at some point, isn't also using human beings as guinea pigs? Like, can you turn that off where it keeps evolving? I guess that's more a question for him. Can you stop the evolution?
So I'll have Bilal answer that question, but I can tell you where we end up at, okay? Generally speaking, when the radiologists give their diagnosis, we have a second check and a third check. Our second check is our surgeons, okay? Because they actually go in and they'll see the tissue and they'll tell us feedback. Now, what's important about that is because in this kind of a system, we actually will get that feedback, right? Right now, we don't. Typically, the radiologist doesn't get any feedback. Then there's a third party, which is the pathologist, that'll actually give us the final feedback, right? That's the feedback Eric was talking about. There's a null zero feedback to radiologists.
Right.
Okay? So the answer to your question is we're going to, and even if it's AI is reading the studies, it's going to still have that feedback from ultimately the pathologist or the pathology AI?
Or I guess my question is more for Bilal. And
Okay, then we'll wait.
Bilal, is there a way to get AI to reach a point of efficiency and just say, hey, stop evolving? Like, can you stop that model?
Just toss it.
Not in a turning way. You can just turn it like
You didn't play football in high school, did you? You did not play football in high school, did you? That is the worst toss I ever saw.
Okay.
A couple of things. So your one question actually touched on, I just counted 4 basically discrete answers is what you're looking for, okay? Let's go to limited compute. There is no such thing as limited compute. First of all, the AI does not operate in India. It does not operate in Laos. It doesn't operate in Burma. It operates on a global Microsoft cloud that, at least ours, which is a little over about $150 billion infrastructure that spans the entire planet. There are data centers in every single continent, and the AI is running on this massive compute farm, just absolutely gigantic, okay? Just Microsoft's alone, okay, it's just absolutely gigantic. So when you access the AI, you're accessing it somewhere in this elastic cloud fabric, somewhere where you're not limited by compute. So you can access it from, I don't care, the Maldives. It's the same compute power as if you're accessing it from Los Angeles. It doesn't matter, okay? You're only limited by the bandwidth connection into the cloud. So to address compute, it's infinite compute. Secondly, the compute scales up and down, okay? Meaning as usage grows, the compute expands. As usage drops, the compute contracts. And that's one of the reasons why NVIDIA's stock is going through the roof and not Intel's, because it doesn't operate on the compute you're thinking it operates on. It does not operate on the same computers. The chip that you're used to, that's in your laptop. If it did, Intel stock would be going through the roof. Ever wonder why it's NVIDIA's? NVIDIA invented this architecture called CUDA. CUDA architecture allows multiple graphical processes to work in parallel, okay? And it was used originally for gaming technologies, heavy distributed computing for mathematical algorithms. That's why I was using games so much, okay? Because basically it's just in games. I'm not going to go into this right now, but in games everything is a polygon. It's a triangle, and when you play like Halo or you play some really super realistic video games, it's basically billions of triangles put together to make it look like a human being. So it's intensive on math, very intensive math. And the NVIDIA chips were designed for math, and so that one NVIDIA card, the GeoForce card, was exceptionally good at math. So these AI engineers figured out that AI is all math. Our brain's basically all math. It's math. And so if I can just do math at scale, which is the best card to do it on? NVIDIA was the best because it allowed you to put multiple NVIDIA cards in parallel because this CUDA architecture that they own. And now you can have hundreds of millions of NVIDIA cards working seamlessly together as one gigantic machine. And that's what the Microsoft Azure AI environment is. Millions and millions of NVIDIA cards in parallel, connected together on ultra high bandwidth electric optic fiber called InfiniBand, and now it's working as just one massive machine. So there's no limitation on compute. It doesn't matter where you're accessing it from. Okay? One more thing. Stop on that one. Let me quickly go to evolution real quick, okay? Because that ties into compute, the evolution part, okay? Machine learning. There's a field of science within machine learning called reinforced learning, okay? I always bring it to the human analogy because it's simplistic, best way to bring it to human analogy, because then the penny starts to drop after a while. Once it drops, and people wind up answering their own questions automatically. Once they they understand that this is basically a human, okay? Our child, when our child's growing up, okay, if our child drops food on themselves while eating, we scold them in some way, okay? And the child learns to be more careful with eating. That's reinforced learning, basically. You're reinforcing something. Child does a good job, you go, shabash beta. That's positive reinforced learning. Child says, oh, good, okay? So that's how we learn. That's exactly how artificial neural networks learn, through machine learning. And so the question you ask, at what point does the evolution stop? It's a matter of at what point you turn off machine learning. And all kinds of machine learning is happening. For example, when he talks to Ava, or my wife talks to Ava, there's real-time machine learning. She knows my wife is friendly. Ava responds to my wife with emojis, hearts, smiley faces. She never does that with me because I'm very scientific the way I talk to her. She never comes back at me with emojis. But to my wife, I often ask her, emojis are being used. That's live conscious machine learning. She's detected my wife's personality, and knows she's friendly, and she says please and thank you to my wife. She never says please and thank you to me. That's simulation of emotions. Okay, so that's live conscious machine learning happening, and as she uses, my wife uses it more and more, it's learning malicious tendencies more and more, and it's being more and more polite, and I think even with Sephora, Bobby, I believe it's also being very polite.
So I have a similar experience, right? So for me, when Eva responds to me, it's very short answers, because she knows from I'm very short on time. Yeah. And it's not emotions based at all, it's very like, with my wife, when Eva responds to her, it's actually friendlier, it's longer, and actually more emotion-based.
Yeah, that's machine learning.
It's not a male versus female, it's about your
personality. It's memory. Once.
Yeah. Is you can turn off machine learning at a certain evolution point of an AI and say stop.
It's kind of like telling a human being, I mean, yes, you could, the same way you could tell a human being, that's it, no more social media, no more television, sit in a room. We'll go be Howard Hughes and become a hermit. You can't learn anymore. You can do that to a human too, but why? Why do it? Right? So the question is why do if you're thinking this is going to become sentient, you're going to take over the world's terminator, if that's the reason why we'll do it.
Well, I'm thinking you've reached a certain point with a data set against accuracy where that model works, and before you move to another model, it requires further testing. Okay, here's what it is. Incremental, systematic, periodic upgrades versus just continuous upgrades without checks and balances.
There is never an upgrade. This is what I'm saying. You're using old nomenclature from old compute, right? These upgrades are version upgrades. You're thinking like it's a computer. That architecture does not exist in
Do you
AI.
upgrade your son?
No, one second.
No. Let me ask you.
Yeah, good question.
Do you upgrade your daughter?
No, I get it. They're continuously evolving.
That's the same thing here.
Yeah, but we're not reliant on them on making business. Like my 8-year-old.
Of course you are. Of course you
Well,
are.
when they become 50, they are. You will be.
right.
When they become 50, you put them to high school, elementary, junior high, high school, and then college. Then you rely on them. So same way, this AI evolves, and then you start relying on it. Earlier stage AI, you don't rely on. This has been going on for 10, 15 years, this AI, right? It's only put in your hands thanks to Sam Altman 2 years ago. But it's been evolving for 15 years. It's nothing new. Artificial neural networks existed in 2004.
So before coming here, I really recently watched what he was talking about. The best way he described it was, for example, TikTok. How long did it take to build TikTok? How long did it build this user interface? He said this is going to be so intuitive. You're going to direct AI to build you an application just like TikTok, do exactly this, exactly the prompt. It's all going to get done within minutes.
We do that right now.
Exactly.
I have 3 AI engineers that do the job of 10,000.
Yes.
We have a company, internally within our AI company, we have a lab called Hive Labs.
It's an R&D lab. Hive Labs is basically engineering, engineering AI. If you go to our company, so actually, it's funny, go to MindHive's Instagram, there is a post that somebody did, one of our digital media people did, of Spider-Man pointing at Spider-Man. Remember that very famous cartoon, Spider-Man pointing at Spider-Man? Because we had this breakthrough where AI could write code. Okay, and so what we did is we did a little test. We made 2 AIs talk to each other, and there was a full conversation. The one AI acted as a customer, one AI acted as the engineer, and the customer told the requirements to the engineer. The engineer output, he said this wasn't good, back, bing, bing, bing, bing, bing, boom. The whole thing was done like instantaneous. It happened so fast, I had to start the test again and retard it to see actually what was going on across the wire. And so one of my engineers said, this is cool. This is like, I said, you know what you just witnessed? You just witnessed AI talking to AI about creating AI and creating AI. And so we did an Instagram post, and the digital media person said, do that Spider-Man point at Spider-Man. It's there. And you'll see that happened a year ago. So yes, it does. It does do that. In fact, we have very limited human engineering internally also, because we rely on AI to do that. Getting back to your point, this concept of upgrades this design pattern, we call those design patterns. This design pattern does not exist in AI engineering. The concept doesn't exist. There's no version upgrades with AI. When you see GPT go from GPT-3 to 3.5 to 4 to 4 mini to 4 turbo, 3.5 turbo to 4 mini to 4.0, now 0.1, that's not a version upgrade. Real quick, 1 second. That's not a version upgrade. The version's still the same with the neural network. It's more knowledge in it and more parameters, meaning more compute on it. This lady's who lifted her hand twice.
I'm not sure if we have a second mic.
Going big time. So my limited understanding is that the more data we put into the AI, then the more accuracy and the more results we're going to get. So throughout, it's not more, I think it depends on how often we feed it data. And I don't think that happens on a timely basis as if you were to upgrade from one system to another. It would depend on whenever they...
It depends. I'm going to talk about this later. Within the field of AI, there are different types of engineering that happens within it. Some kinds of AI is narrow AI. I'm going to talk about that later. Okay? And in that situation, you do have to give it more data. Some is broad scope AI. Some is generative AI. Some is autonomous AI. Some is self-supervised learning AI. Some is artificial general intelligence. So I have to get into engineering, how it all works. This technology, the layperson, is just generally called AI, right? And so when people read news or hear stories or what, it's limited data. There's not enough knowledge out there in the world right now from non-engineering perspective for you to be able to discern which type of AI needs what and what its pros and cons and limitations are. That's kind of where we come in and we help you with that. But the answer is yes and no, depending on which AI you're using. It's like saying certain cars need unlimited. Certain cars can drive 500 miles, and that's generally true. No, it's not generally true. It depends on what kind of car it is. Maybe an electric car can't drive 500 miles. Maybe an 8-cylinder car cannot drive 500 miles, drive 200 miles. So it depends, right? Can cars generally drive 500 miles? Generally, yes. So does AI generally need to be trained more? Generally speaking, yes. But when you go into the field of AI, if it's self-supervised machine learning AI, no, it learns itself. And where data doesn't exist, it'll simulate and create its own data, just like I am a human. I can go and I can study the basics of math, okay? And that's it, I'm done. Now, if I give it enough time, I can come to the conclusions and I can invent algebra. And after all, we did invent algebra, right? It wasn't something that came down from a problem. We thought we invented algebra. It will invent algebra too. It has. It's invented chemical compounds right now that have never existed before. That's how precision medication is coming out now. New kinds of chemical compounds for drugs are being invented by AI today. The data never existed. It's not Google. It's not just indexing old data and regurgitating and giving it to you. It's cognitive. That was one of the first things he said the first time. It's cognitive. It'll think where humans can't think. That's how it's able to invent new drugs. It's invented new ways to create hydrocarbons in fuel to propel a rocket ship much more cost-effective before. Why? Because it knew the principles of whatever the heck it is these guys do to create energy, whatever the petroleum engineers do. It knew the principles of petroleum engineering and then invented new kinds of fuel that allowed SpaceX to launch a rocket now that it couldn't have done before in that price. So that shows its ability to create data where data doesn't exist, to your point. Why would you turn off the evolution? My God, breakthroughs are happening with medicine, breakthroughs are happening with carbon engineering, breakthroughs are happening with electricity, breakthroughs are happening with the ability to excite molecules in the air to make molecules attach and do things, which one day will be the Star Trek replicator where you go and say, I'd like a baked salmon, please, with a creme brulee. Thanks very much. Turn it, come back, there it is. It's through the excitation of molecules, create stuff with stuff that exists before. Why turn off the evolution?
Well, I mean, the other okay, wait, look, so you're going to have the floor for yourself, all right, guys? So, because you guys are going back and forth and stuff, but look, it's not even this question of creating. We have so much human knowledge and information right now that I will bet you dollars to cents we could solve cancer today.
Yeah.
And I'll tell you what the issue is, right? So, Burju, have you ever been to medical conferences? Your first time? Okay. All right. Adam Bay, any medical conference? Sometimes you go? Many, many years ago. So, let me break it. So, Adam Bay is the CEO of Medical Park Leaf Systems. How many hospitals now? 32? 1? 35? You guys keep adding on me, which is good. So they're the only publicly traded hospital chain, okay? And sitting next to him is Burju, who is the mastermind of it all. She's the CFO of the hospital chain, okay? And they're both very dear friends. So they just came in in with this amazing conversation. But the reason I'm asking you this, so Adam Bay, when you used to go to a medical conference, there's 10, 20 lectures going on at the same time, right? Now, every hour, you're trying to figure out which lecture to go. You go to the hall and there's posters, scientific posters. How many can you really read, right? If I go to the radiology conference in America, in Chicago, once a year, it's called RSNA, there's 30, 40 lectures every hour. And when you go to the hall, there's thousands of posters of latest information, people did research that got accepted and published. But I can't go. I go to maybe, obviously, one lecture an hour, and I can't read all the posters. So when I'm finished with the conference, I might come out with 1% of the information, maybe 1%, right? But with AGI, with AI and AGI is a little bit, AI, like you said, is too broad. AGI is more, it's sentient. It's actually, it's not sentient. It's,
That's the kind of stuff.
yeah. So it actually, yeah, it's cognitive. It thinks, okay? This will have access to every poster at the conference, every lecture at the conference, every slide of the conference, and we'll put together all of that data. You guys understand what's happening? All of that data, and tells you in this year's conference, this data set coincides, and therefore this is the cure for this kind of a cancer. We get 1%, it gets 100% of that information. And that's just one conference, right? So Dr. Rahman, one cancer conference, how many cancer conferences in the world happen every year? Probably hundreds, right?
Like single one ASCO, we have 70,000 people.
70,000 people at one conference.
Same
My
thing for
point
RSA.
being, so much of the human information has already been lost that can in fact be gained back by the information we can fit in here. And we may already have the cure for many of the diseases. In Turkey, you have a centralized medical database, right? All the patients, everybody has. Can you imagine how much information you have just at Medical Park? How much data you have that can be analyzed at this level? And it'll predict for you, and I haven't even done the hospital talk, but it can actually predict what patients that came in with what possibilities, how long they're going to stay in the hospital for.
Bed management, everything.
Right. That you bring back to your office and leave it there on the table, right? Imagine how much information there is that we can actually get from this, right? So I was actually just, talking about how it's going to change. It's already changing radiology.
Can I add one question? It's very important. I know I was listening Bilal, and it's very interesting thing. From my side, there's a lot of clinical trial. Dr. Sana knows pharmaceutical companies, they are spending billions of dollars.
Yeah.
And they are totally dependent on radiologists, and they say you need to get the measurement, and for one measurement, single measurement, I do a lot, it takes 20 minutes minimum, 20 to 30 minutes. But with this system, the measurement can be done. I don't want to say, like Bilal, you took a picture yesterday, right? And only we go like a very simple measurement, like long axis and short axis, and then we have progression or regression part.
Yeah.
With this simple thing, if we can summarize, boom, with just a single set. So we are getting more accuracy, we are getting less time, and definitely, good result within like a fraction of the second.
And predictability, right?
Stability.
Predictability.
Exactly. Like,
ability to predict.
Exactly, and like the R score, right? Bilal and I, we had a discussion. The R scoring, we need to get the input, the R score, and that R score is like, we can detect the predictability and like the progression or regression of the disease to define everything. So we just adding the input, which is Rehana asking, like we can go for further enhancement. So this is what I think, like.
Yeah.
Can I speak real quick?
No.
On the point.
I'm just kidding. I'm just kidding.
Dr. Sana just said that we probably have a cure for cancer today. In the lab, we actually do. Did you know that? I'm not going to go through the details. It's too much right now. In chimeric antigen receptors, CAR T therapy, right? Currently at the Mayo Cancer Center and the MD Anderson Cancer Center, currently right now, there is a breakthrough in CAR T cell therapy, right? Which actually is a cure. Do you want to know why we don't have an enhancer there? One guess. Two guesses. Why is that not being dispensed right now through the oncologist? Anyone know?
Money?
No, there's $20 billion a year being spent right now on cancer research. It's first, and then after that it's cardiology, which is $14 billion a year being spent on that. That's just the FDA trials. I'm sorry, that's not the research. The FDA trials alone, stage 1 through 4, not post-commercialization, just stage 1 through 4, is $20 billion on cancer, but it's still not on the market. Come on, and one other reason why. Quick answer, tell me, why is it not on the market right now? Yeah, yeah. Yeah. Yeah. Yeah. So I said they've already found the cure. They already know how to take the cell and localize it, make it go back and kill the cancer at a cellular level. They know how to do this right now. It's being done in a lab.
So why
right
is it?
now.
What's the answer?
The reason why it's not in your hands today is because the FDA trials 1 through 4. At stage 3 is where you get out of the lab off the mice onto the humans, and you have to find a healthy human, okay? And so through attrition, to be able to take that epitope, okay, and to test it right at the molecular level and see if it goes back, you need to do it on healthy humans. And for each cancer, the demographic is different, okay? So to be able to find a sample set of 25 males between 60 and 65 that they're going to test on, healthy, who are willing to take this therapy and potentially get sick, the attrition rates are 98%. 98%. So you got to go through 10,000 people, eliminate 98% of the people to get those two, okay, that may or may not test fine on it, and then get it approved through clinical trials for that particular form of cancer. And we were talking about multiple myeloma in this case, okay? So the FDA trials is the problem. And within the FDA trials, the problem is that finding the humans. So that's what InnovaCore and we are actually going to be working on with Dr. Sohail Rao right now, is to simulate the molecular structure. Don't get the human out of the equation. Do your testing on human simulation. I said we can simulate the spine. We're looking at simulating at a molecular level what would happen that molecule would dose that person, and then do that at scale. So you don't have to go around looking for 10,000 humans that are healthy and go through the attrition and find 2 and say, oh, this is going to work, and that's only for multiple myeloma. It's not that we don't have the cure for cancer. We do. We theoretically have the cure for cancer. And the reason between theory and real life is the FDA makes it real life. Labs is theoretical. They have it right now. We just can't put it to market because of the inability to test on enough humans. We just can't get them. Well, if Dr. Sohail Rao and we just, actually one of my clinicians, Dr. Saimani's, I just talked to this morning. I said, get the paperwork going immediately with NovaCare, because we're going to create AGI-powered simulation models for him at InnovaCore and start to simulate certain kinds of immunotherapy that they're doing in a virtual body, and then see if that works. If it does, we'll start to scale it from there. And if it really works, he's going to take it to the FDA and say, let us try this. Because it's better, I mean, the chances that you are going to kill somebody, a real human, or actually make them materially sick by testing them versus making a computer sick, I would rather make the computer sick all day long and not a real human. So there's a very good probability that they believe that, and Hank also agrees, Hank Chaudhary also agrees, that if we took this to the FDA in simulation models, they'll say, you know what, go do that. We'd rather do a simulation model with the accuracy of simulation than random testing on humans, or, they can't even do like decentralized clinical trials. You know that, right? You can't do a decentralized clinical trial. You can't have the same epitope tested in India that needs to be tested, for example, in Alaska because of the demographics, right? So even there, you're geographically limited. In this case, you could simulate an Indian body, a Turkish body, a Chinese body, an Alaskan body in this situation. So they believe that if Deviate Ecosystem MindHive can prove out simulation models, then they'll take it to the FDA and get it approved. And then one day you may have cancer drugs. Yes. So I just had my Vice President of Healthcare Solutions today contact Innovacore, who we already have a contract with right now. We already signed the contract with them. Innovacore to start to put out a proposal for how long this will take for us to prove that this simulation can actually work. If we can prove in a pilot program that simulation can work, then they'll pull the data in, and at scale we'll do some simulation testings. At scale, we'll get the efficacies up, right? And at that point, when we believe it's robust, then it's up to them to take it to the FDA. I'm just a tech guy, right? I mean, I can't do that. Yes. I'm not understanding the question, so I would you understand what you said? What did you say? One more time?
Can you speak in the, yeah.
No, we know the treatment. So you're saying diagnosis. That's what you're saying. You're saying take the person who's got some symptoms and then analyze it, right? We've gone beyond that. We're talking right now about, we know the cancers. We know at a gene level, at a molecular level, what the problem is. We've even found the cure to fix that problem, is what we're saying. We're saying that the FDA trials that it takes, the process, the bureaucracy that you go through to get that cure into a pill and actually be able to have a physician like her administer it, that process is 14.7 years. Did you know that? 14.7 years.
So let me give you a different example.
For one epitope.
It's like an airplane and trying to figure out what happens when the airplane flies and how it crashes and what kind of designs to do on an actual airplane, right? You're going to be extremely limited as the number of airplanes you got available to do this. Whereas creating a simulation model of how that airplane is going to fly, what kind of winds are coming, what kind of conditions, and you can simulate all of that and predict without crashing a real plane 100 times, right? So very similarly, there's companies doing this programming to simulate the actual cancer cell and the cells that will attack it, and what will happen when you have this kind of a cancer attacked by this kind of a, right? So but instead of human, you're actually you're simulating the model.
Let me give you one example real quick, okay? For a localized cancer of multiple myeloma, the simulation parameters we estimated were approximately, okay, to test one epitope, were approximately between 250 to 500 million data points to be able to simulate that particular cell therapy for multiple myeloma. 250 million to 500 million data points. Currently, right now, the New York Institute of Finance has an econometric model that will simulate that if I in Istanbul go and I pull out 10 lira from my ATM, what is the global effect of that? That simulation model is about approximately 12 trillion parameters. For money, these guys will go to 12 trillion parameters to simulate what will happen if I pull 10 lira out of an ATM. But when it comes to 250 to 500 million, we can't simulate that. You got to do it on a real life human. Go figure. Well, yeah, those are the human subjects that are done in stage 3 clinical trials. Yeah, they get paid to do it, and they take $75 to get sick. Huh? $75, yeah. Much more than trying it on humans. Much more, because they're not doing biomarkers on the humans. If they say, if 5 guys show up and say, give me $75, they're like, come on in. Are you between 65 and 75 years old? You're white American? Come on, you're welcome. They're not even doing biomarker tests. They're not even checking at a biomarker level, is this person the right candidate? It's like anybody show up as long as you meet the litmus test, come on in, take the injection, let's hope you don't get sick. No, the simulation models are far more accurate. Yeah, far more accurate.
All right.
I'm passionate about this subject.
You have your time. All right, so we're going to finish, at least in my part of it, in terms of transferring. So radiology is one area that's obviously being affected by AI. Pathology is actually even more affected, okay? Because in pathology, in radiology, we still do differential diagnoses. In pathology, you actually have the final diagnosis, right? And how do you get there? Generally speaking, you're taking tissue samples. We just went through the whole lab and stuff. You take tissue samples, you put different colorations to them, you get them to look a certain way, you look them under the microscope, see the shape of them, what color, what shape. Well, once it's digital information and it's pattern recognition, you're not going to need, you don't need humans to look at it anymore.
And you don't have to stain the sample anymore, no stain.
You don't have to stain the samples, none of that stuff, okay?
Because the staining is only there to help the human eye. The human eye can't pick up those patterns, so you stain it.
Okay. I'm going to repeat this one more time. Yeah. We as humans see things. AI is reading code. It's not looking at something, it's reading numbers, right? Just like I said, the matrix.
No, he's talking about density. The camera on your phone right now is 12.5 megapixels. If you have the iPhone 14 or high, I believe it's 12 megapixels. You know how many megapixels the human eye is? It's less than 1. Our human eye is less than 1 megapixel.
So, answer being,
and that's if you got 2020, actually 2030.
But again, right? I mean, but we're still talking visual versus data-driven, right? Visual versus actually looking at numbers. So, pathology is definitely on the brinks of extinction. Okay. So when you have AGI-powered systems, you're going to analyze the slides faster, more accurately than any human pathologist. Okay? You're going to be able to pick up minute details down to the structural, the cellular structure level that the human eye will not be able to see. And I know I hate to even say this stuff, but you got to be, especially you guys as the next generation of medical students, right? You need to know which area of medicine you got to go into. Okay? You can still go into pathology, but you need to own the pathology labs. Okay? Because this work has to be done someplace. But reading as a reader, as a clinical pathologist, as a radiologist who's just reading studies, that's, I will tell you within the next 2 years, the kind of work we're doing already, I can tell you right now, my diagnoses with what we're doing right now with our imaging. Adam Bay, you said you're a radiologist, read 100 studies a day. That's a lot, right? But what if you can read unlimited amount of studies a day? From all 35 locations, instantaneously. We have ER doctor sitting here. His complaint from the US is that he doesn't get his readings back for hours. Patient comes in, gets a CT scan done, and hours go by before he actually gets a result back for an emergency room where he needs to make a decision, life. I don't know how it is here in Turkey, but in the US, oof. What? No, they order. They will order the studies to check, except the results don't come back for hours.
So what they consider an emergency, they have 4 hours. They are allowed 4 hours from the hospital, but they'll take 4 hours, sometimes more, because of shortage of doctors.
Yeah. So we're actually going to get rid of that scenario with this. Within the next 2 years, you're not going to need it. Okay? That's exactly what I'm saying. Yeah. So, but same thing with pathology, right? Now, what's interesting is with AGI, you actually will have multiple sources to pull data from. So right now, again, the pathologists, maybe they have more information. As a radiologist, we don't get much information. Neck pain, back pain, headache. That's the diagnosis we get, right? But with this system, when you have all of the different types of people involved, you know, you've got genomics, patient history, you've got more diagnostic pictures, you got MRIs, you got CTs, you got histopathology. When this is making a decision and giving you a decision, it's going to have a lot more information available to it. Again, we talked about prognostic modeling in radiology. This is also prognostic modeling from pathology, right? We can predict disease progression, patient outcomes, and I know it's a pet peeve for Rehan, but so we can actually predict what, you know, in terms of the patients, what's the risk, what kind of treatment that we can actually get from the tools within the system rather than relying on actual human beings. Personalized therapy recommendations, again, we can have pretty much unique profiles for patients and what kind of therapy is going to be the most effective kind of treatment on these kind of patients. You have genetic mutations that we have markers in pathology. You've got targeted therapies that we can do in pathology. So this, all of this information comes together to give us the best possible way of treating that patient or diagnosing that patient. Okay? You can also have in terms of automatic workflow. So AGI will completely, well not completely, will actually significantly help the workflow for the pathologists and for the hospitals, right? So basically streamlining the entire pathology workflow, specimen tracking to reporting. This is one of the biggest problems and biggest, so I did a year of pathology at UCLA before I did my radiology residency. This was a huge problem, which is specimen tracking, right? You get a specimen and then it goes from station to station to station to station to station. I don't know if you guys ever done pathology rotations or not. That's how those slides actually end up getting done. They go from one station to the next, to the next, and next, and by the time you're done, 10 or 12 human beings have touched it. Right? It's really a problem because so many potential mistakes can actually happen in this. So, you know, so that will actually get eliminated. Yeah.
And why? Because we have a biological platform, right? And then the other side we have imaging, which is not a gold standard, but we do it just to make sure, like or I can say invasive and non-invasive. So that means the AGI covering both invasive
And non-invasive.
Non-invasive, and confirming the gold standard.
Yeah, but the other point is, Rahman, is that the amount of information that it has available to it, right, is way more than I do as a radiologist or you do as a radiologist, right? And the predictability that it's going to bring. So there's a lot. This is the other. So if you look at this data, percent reduction in diagnostic errors with AGI-powered error detection and quality assurance, right? False positive errors, 65%. False negative errors, 72%. Delayed diagnosis, 58%, and misidentified tumor subtypes, 79%. This is the numbers are really, I don't know what they are against in Turkey, but in the US it's really gotten, it's really crazy. Enhanced education and training, AGI-powered virtual training platforms can pretty much simulate, again back to the simulation, really very complex pathology cases, training the pathologists or exposing them to rare conditions, really getting them to have real-world practice without necessarily having all those, finding all those tissues and those kind of pathways, right? So this is going to be a very, very good teaching tool for our purposes. So scalable pathology services, we can have remote diagnostic capabilities. So basically you can have a lab or pathologist sitting in one place for all over Turkey, just one place, and they can all be actually looking or reading. But it's not even really reading the study, right? Because when AGI actually gives you the diagnoses, you can handle a vast amount of information, right? And a huge number of cases can be done pretty much in the same day versus being limited by the number of pathologies that you have. And we have a major pathology shortage in the US. I don't know how it is here, but and that's also driving, you know, potential of this scalability. Anyway, so integrating genomics and molecular pathology. Now, This is a whole different arena that's coming up, that pathologists are becoming so significantly valuable for prognostic purposes, predicting purposes, from the genetics of the patient. Okay, so again, I don't want to go through repeating all this stuff, but I'll tell you that I want to get to Bilal an hour ago, but I'll get to you now. And we talked about bias mitigation and standardization of diagnoses, so we'll skip that. And future-proofing the field is going to be rapid adaptation. So so the growth of pathology and AGI is going to be the fastest. This will be the fastest field in medicine to grow using AGI, no doubt about it. Okay, we're already doing it, so we're pretty much there. Yeah. Do you have the mic? Gabe? Yeah. You will.
Which is, the same thing that goes with vaccinations, right? So if we don't look at the get-go, the life of somebody from the beginning, right, pediatrics, how can you control this further along, right? It still comes down to treating them with pharmaceuticals, right?
Yeah.
So the natural essence of
Yeah.
being able to take care of a patient and treating the baby comes down to pediatrics.
It's right. This is where that's, Sitar, right? Genomics and molecular pathology. That's what this is at, right? So when a child is born, and in fact, before even the child is born, you can actually run all these tests. And this is going to be the way it's going to be. And it's going to.
Those are the biomarkers you look at.
Yeah.
When the fetus, if you want to, when the fetus in the mother's body, you can look at those very biomarkers and know what's going to happen and treat for it if you want to in advance.
Well, I mean, that's the problem today, right? I had a child a few years ago. Not every doctor treats or looks at it the same way, right? So if there was a program that you said, look, from the get-go, I want my children to be looked at, they're to be tracked, right? I think that's really the start point to the future change. It's either that or we capture the elderly today, right? From the home health systems, from those
2 years. 2 years, Siddhar. 2 years. I'm telling you, you're going to be able to do that. And I know it's like right now people are like, oh my God, what do you mean 2 years? How are we going to be able to do that within 2 years and stuff? The AI, the AGI train is exponential. The amount of information and data analytics we have is exponential. It's not this regular trend of a line. It's like this. So what we did 20 years ago, we can do pretty much.
I'm working with Dr. Rizwan Naeem right now, who's the professor at the Genomics Research, which is the Albert Einstein College of Medicine, and the Center for Genomic Research. And he and I become fast friends. He and I become fast friends. And I'm giving him my AI for free.
I don't know what these guys do. I don't. I'm not going to profess to know what these guys do. I don't know what these guys do. All I know, I'm going to give them the tools to do whatever they do better. Okay? I don't know what these guys do. But yeah, I'm assuming, yeah. I mean, I'm assuming if that's the logical progression, right, then.
The question, I guess, comes to you now, right? How do you imagine rolling this out, worldwide, right? Because people don't trust AI necessarily, right? They think it has a flaw, they think that,
Thank God those people are not the decision makers. The reality of it is that the naysayers are not the ones who understand the engineering. The people who want to use it, who actually will make the difference, are the forward-thinking people that are working on cutting-edge cancer research, that understand math, that understand the power of AI. They've researched it. They've gone down. They've been working with the stuff for years. They get the power. The decision makers, the ones that are actually going to propagate global change, are the people who get it. The naysayers are the people who don't get it. It doesn't really matter whether they get it or not, because at the end of the day, the most they'll use it for is maybe to solve a math problem for their kid's high school exam or something, or they might use it for, I don't know, maybe doing their taxes or something, narrow use its users, right? So look, we have 130,000 followers on one of our pages, just one of our corporate. The AI's ethics don't need to be managed. It is the human that misuses it whose ethics need to be checked, okay? The AI is not sentient, meaning it's not going to evolve on its own. It's not going to go out there and do anything. You can use it for nefarious purposes. You can use it for bad things if you want to. And so we as AI companies, we put ethics filters on the AI, preventing you from using it for certain things, okay? There are keyword checks that we put on it, filters we put on it. For example, sexual words cannot be used with it. It'll stop. There are other kinds of known behavioral patterns that are considered by society to be negative in some way. Those are inbuilt in the ethics filters. And by default, it won't let you do those things with it. But the ethics is not, the AI itself is not ethical. It's the human that misuses it that's ethical. The same way the unethical human can go on the dark web and use BitTorrent or use the onion router, Tor, and do unethical things with the dark web. It's not the dark web's fault. The dark web's just technology. It's the people that used it in a bad way. So keep that in mind. Okay? When you say AI ethics, that's an oxymoron. How can a computer be unethical? It's how you use the computer that's unethical. Discuss what? When you said it, discuss what? Sure. Yeah, of course. The ethics are being discussed all the time. But ethics have been discussed since the dawn of mankind, right? It's just different problems have create different ethical issues, right? Are people discussing ethical use of AI? Sure. Have people been discussing ethical use of Google? Sure. Have people been using ethical use of emails and spamming people with junk prior to that? Sure. We're always using, I don't see what the big deal is with ethics of AI. I mean, there's so much hoopla around this ethics of AI thing, right? I don't quite understand. What are people getting all suddenly ethical AI? I think the real issue is that AI is so powerful that what you can do with just ChatGPT alone is infinitely more than you could have ever have done with Google. So that scares people because it can give you such incredible answers so accurately, so fast on any topic, that when people learn to use it, they suddenly realize, oh my God, this thing is too powerful. And then so they wonder, oh, what about AI ethics? No, man, it's just what about your ethics? Okay? It's not the AI's fault that it's powerful. It's your fault if you misuse it. But no, people have been talking about AI ethics. Of course, they talk about it a lot. Yeah. Different use cases, different ethical situations. Okay, you guys ready to be blown away? Ready, Doc? Okay. Okay, how do I move this thing forward? Just press this? Ooh, it works. Okay, so real quick, if we go back. So this is a, what's that? Artificial neural networks, the brain behind all of it, okay? Very high level of the brain. So this slide is, I'm going to go through this fast, okay? So I also have not read the slideshow. And at the end of the slideshow, the last slide is a timer. It tells you how long it took me to make this slide, okay? But I haven't read it. So I don't know what this says. I trusted my AI. I asked him last night, what are the topics I'm speaking on? I think you sent him a WhatsApp last night. I just looked at his topics. He told me there are 3 topics. I said, great. I gave the topics to my AI. It wrote an outline for what the presentation should be about. I put it in the stool. It created it for me. And the only time I spent building this, which you'll see, I think 17 or 18 minutes, was actually putting these cool videos and stuff in there. Okay, because I told you I was going to win the prize for a better looking presentation. Okay, so I spend more time on like creative stuff now than I do actually on the presentation. So this is an introduction to key concepts. We're going to talk about concepts, right? Remember you were saying earlier, AI needs to be trained. Those are some concepts we need to get, vernacular we should get good with, okay? So key concepts, applications of artificial intelligence, artificial general intelligence, artificial neural networks, the actual brain behind all of it, very high level conversation about it, with a focus on advanced AGI model, AVA Fusion. So I'm the guy that invented the Fusion model, and I gave her the name Ava, okay? And so we're going to get into AVA Fusion. Okay, so introduction, transformative technologies. So AI, AGI, and ANN are revolutionizing business operations, enabling great intelligence, okay? So a real introduction to what you're about to talk about with me here is really how transformative this tech really is, okay? How it is going to change the future and how it's going to reshape stuff, and more importantly, its use in business operations, including clinical care, Okay? We'll get into that in another slide. Again, I want you to think about something I told you earlier when Dr. Sana showed you his slides that he made. Remember I told you it's the logical format of the layouts of the slides to help you down a journey that's cognitive, right? To even create a slideshow to teach somebody something, the way you outline your data, your information needs to be logical for the audience. So the fact that we're going to go through transformative technology first, how it's reshaping the future, and it's how it's being used in business, it's actually logical, the flow. So this was AI actually creating that flow for you. Shows you how cognitive it is, okay? Okay, so by leveraging the power of AI, AGI, and ANN, businesses can achieve unprecedented levels of efficiency, okay? I'm going to show you, and we've probably talked about it, but efficiency is defined by different people in different ways. I don't know what's efficient, right? If my son shows up to school on time and actually gets good grades, I think that's considered efficient, okay? He's an efficient student, okay? I don't know what efficiency is, but wherever you use it, your efficiency, accuracy, predictability, reliability, consistency levels are just not linear, not logarithmic, parabolically better than anything I've ever seen any human ever be able to do, okay? Okay, so what is AI? AI refers to the capability of machines to perform tasks that typically required human intelligence, okay? Cognitive thinking, all right? Such as decision making, problem solving, and learning. As humans, if you really go down to the core of who we are, I mean, we're really just trying to solve problems all day long. Kid's trying to solve problems when he's a baby, he wants to drink something, he cries. It's his way of solving the problem, okay? And as we grow older and older, just that the problems become more complex. A physician's problems are more complex, engineers are different kinds of problems, but our problems become more complex. Our choices we make in our life become more complex, and hopefully we keep an open mind as we grow older and older, and we learn better and better, and the fact that we have an open mind allows us to learn more, and if we learn more in a structured, unstructured way, hopefully our ability to solve problems and make decisions becomes better and better, right? So AI just works the same way, right? It just makes decisions for you if you let it. It'll solve problems for you if you ask it to do it for you, and it's going to learn along the way, okay? So that's really what AI is, all right? Now AI is task-specific intelligence. Imagine there's a human whose sole purpose on the planet is to solve math. God made somebody who just knows arithmetic. 2 plus 2, 4 plus 4, 8 plus 8, 16 plus 16, and a few derivations that I can do multiplication. Then they know the operators, right? They know the addition, subtraction, division, multiply operators, and that's it. That's all they're there to do. And they will not solve an arithmetic problem for you unless you ask them to solve it. That's narrow AI. Narrow intelligence to solving mathematical problems that only if you prompt it with the problem will it respond with the solution, and that's it. That's all it's going to do. ChatGPT is a great example of that, okay? ChatGPT is a prompt response model. Prompt it, it will respond. And frankly speaking, the response it gives you are quite, as you guys have seen, amazing. But it's just a prompt response model, so we call that narrow AI. It's narrow to its knowledge that it has. It's not going to learn much more. It's static. It's learning. It's static at the version number of the language model that OpenAI has published, which is currently at version 4. So the knowledge is static. It's not machine learning anything more in the background. They just publish that model. It's static. And it's going to, you prompt it, it's going to respond. Prompt it, respond. That's narrow AI, okay? This tool that I use to create this PowerPoint presentation, it's narrow. You give it some context, give it some data, it's going to output a beautiful PowerPoint presentation. It's very intelligent, it's going to lay it out beautifully, it's going to pick the pictures for you, write the text. Very narrow just for that purpose. And so on and so forth. There are a lot of narrow use case AIs out there that you can use that are very task-centric prompt response models. Tell it to do something, it's going to do that job for you. Machine learning algorithms. You got to go a little bit into machine learning to be able to move into GI. Now AI systems are built using machine learning models, okay? That's how they become smarter. That's what I was saying to you earlier, Dr. Rehan, there's no versioning in them, they're constant machine learning in the back. So it's not like it versions, it just learns. Just like a kid learns, you don't version your child, okay? So now AI systems are built using machine learning models, which learn from historical data. So think about it, you go to school, you picked up a textbook. Before you read that textbook had been published a year ago. That's historical data, right? You go to medical school, you're studying historical data. something was taught to you in med school and university on economics. It was some economist 10 years ago that wrote a paper that set a precedent for that economic principle that you're studying today. Isn't that historical data? We all learn off historical data. Who the heck's coming up with new inventions? Everything is a derived work of art in life. Everything is. There is absolutely no new invention. Everything is an invention off an invention. So everything's based on historical data, so we know this. And so the machines learn off historical data the same way. Okay, so don't say that, hey, if you give it terrible data, it's going to get bad data. If you give a child terrible textbook, they're going to learn bad stuff too, right? So we're careful about what we train the machines on, just the same way we're careful about what you train your child on. In fact, I think we'll have less quality control when it comes to our kids, right, in terms of letting them use Instagram and free-form, unstructured learning than we do with AI. AI's supervised and unsupervised learning principles are actually very, very, very rigid into what goes into these systems, okay? Anyway, so now AI systems are built using machine learning models which learn from historical data to then make predictions or decisions the same way you do. If you learn good textbooks, you're going to make good decisions. You learn terrible textbooks, you're going to make terrible decisions, okay? Common algorithms include decision trees, support vector machines, and deep learning models such as artificial neural networks. I'm going to get into what ANNs are later, okay? But basically, one of the ways it learns is using this logic called ANN. It's the same way your human brain works. Same way we learn as a brain, the same way this thing learns as a brain. It's constantly evolving. Application of AI, we found, I mean, it's just everywhere. It's just absolutely everywhere. And if you don't see it, you're disconnected from society because it's everywhere. It's just sometimes you don't have access to know what people are doing with it, but it's being used by the United States Department of Agriculture to come up with new kinds of fertilizers to fertilize agriculture will to get better crop efficiencies. It's being used by NASA. It's being used in advanced medical research. It's being used potentially in hospital systems. It's being used for, anybody got a self-driving car here? It's driving your car, okay? It's driving your car. It's being used in Netflix. It's being used in YouTube. It's on your Apple Watch. It's in your iPhone. Hello, Siri. That's AI working for you. It's everywhere. It's just that ChatGPT 2.5 years ago came on the scene and gave you unstructured access to AI. Let me explain what that means. You can talk to it. Previously, you could not talk to the AI in a Tesla. You couldn't really talk to the AI in Siri. She'll just tell her what to do and she'll do something for you. You couldn't have a conversation with her, right? You couldn't talk to the AI in Facebook. It just gave you your feed using artificial intelligence. You couldn't control it, right? You couldn't interact with it. That was called structured access. So previous access to AI was always structured. It was limited. It was behind the scenes and it served a purpose.